good evening. I'm Dr. Priya, Assistant Professor of Nephrology at Osmania General Hospital, Hyderabad, and Secretary for WIN Telangana State Chapter. I'll be a host for today's webinar. April has been a busy month for all of us as nephrologists. After a lot of learning, skill, networking, and fun at WCN, we are here today with another WIN India, WIN Telangana State webinar with an important theme for today, that is hypertension. A major advance over the past 2 decades has been the recognition that the spectrum of hypertension-induced renal damage extends much beyond the known benign and malignant nephrosclerosis. The pathogenetic mechanisms of hypertensive renal damage are broadly classified into 3 categories: the systemic blood pressure load, the degree to which such load is transmitted to the renovascular blood, and the local tissue susceptibility to any given degree of barotrauma. So on these lines, we have interesting talks and cases lined up for today's webinar. So without any further ado, let's get started with the first talk. We have eminent nephrologist from Canada, who originally hails from Mumbai, India, Dr. Swapnil Harmath. And to chair this important session, I invite the chairpersons. So may I take this opportunity to invite Dr. Manisha Sahai, Professor Head Department of Nephrology from Osmania General Hospital, Hyderabad, Dr. Srilata, Senior Consultant Nephrologist from Kerala, Dr. Rajshekhar Chakravarti, Senior Consultant Nephrologist from Yashoda Hospitals, Hyderabad.
So, good morning and good afternoon to all of you. Good morning. Welcome, Dr. Swapnil. Pleasure to have you here. We are all big fans of you here. So, just in the way of introduction, though I'm sure you are known to everybody in India. So, Dr. Swapnil hails from Mumbai originally. He is a nephrologist at Ottawa Hospital. He is an associate professor in the Faculty of Medicine, and he is also appointed to the School of Epidemiology and Public Health at the University of Ottawa. He is associate scientist in the Clinical Epidemiology program at Ottawa Hospital and Research Institute. He is an American Heart Association certified specialist in clinical hypertension. His primary research interest is using knowledge synthesis. He works with hypertension patients with AKI. He has authored more than 200 papers in peer-reviewed journals, and he is also co-creator, we all know, of Twitter-based Nephrology Journal Club, NephJC, and he is also a panelist on the Freely Filtered podcast, so very popular figure on social media. It's a pleasure to have you here and excited to hear about what you have to say about hypertension and kidney. Is kidney the culprit or the victim of hypertension? Floor is all yours, Dr. Hiramath.
Thank you. Thank you again for that introduction. Let me just start sharing my slides. Give me 1 second. Okay, I hope I'm clearly visible here. Thank you again for that introduction, Dr. Sahai, and thanks for inviting me here. In terms of disclosures, I don't have any financial conflicts with drugs or device. I do have some research funding. I'm a member of some guidelines, but whatever I'm saying today is just personal opinions. And we'll, over the next 15-20 minutes or so, we'll look at the variability there are many guidelines, right? And we like guidelines, but the guidelines are so different, which is kind of interesting to see. But we'll talk a little bit about some basic stuff like blood pressure measurement and adherence, and some clinical discussion about the blood pressure management in chronic kidney disease. So in terms of just background, hypertension prevalence is actually increasing over the years. This is from the Global Burden of Disease study. And this is not just because of the aging population. If we look on the right side, even the age standardized blood pressure rates are increasing. But unfortunately, blood pressure control itself is worsening. So over a period of time, and this is before the COVID pandemic, I'm sure things are way worse now, post-pandemic, that the blood pressure control rates, despite having better drugs, despite knowing why blood pressure is bad, it's getting worse. And again, this is from the Global Burden of Disease. People think, it's the high blood pressure, malignant hypertension that is bad, but there are very few people, if we look at the overall attributable risk, if you look at 180 or 160, there are fewer people there who have bad things. Most of the people who are going to have bad things happen from high blood pressure, like, stroke or heart failure, are in the 120 to 160 category. And this is why it's really important to look at all numbers and try to drive down the blood pressure. Now, whether the blood pressure is the victim or the culprit, this is a really nice study that I like to show, which took all the large blood pressure trials and they looked at outcomes. And what we can see here is that reducing blood pressure, this is an effect of 10 millimeter reduction in systolic BP. It reduces the risk of major adverse cardiovascular events by about 20%. The big ones are stroke and heart failure, which are close to 30%. All-cause mortality is about 10%, but look at kidney failure, right? The effect size of kidney failure after reducing blood pressure is hardly there, 0.95 with the confidence intervals crossing 1. So better blood pressure control. The reason we look at blood pressure control is not just for the kidney, but it is more for the brain and the heart of our patients who have chronic kidney disease. And if you look at guidelines, in the American Heart Association was very simple, 130/80 for everyone. And the Europeans, on the other hand, and the International Society of Hypertension since has followed suit, they are 140/90. And the KDIGO, on the other hand, KDIGO went with less than 120 unless it's a transplant. So it's very interesting to see that all these societies have looked at the same guidelines and they have come with, it's like a buffet of delicious food where, you can pick what you want. If you like 140, choose 140. If you like 120, choose 120. But the way I think about it is that lower blood pressure is better. And even if you don't achieve 120, the way you should be looking at is that should be our goal. Even if we don't actually reach that finishing line of 120, going towards 120 as long as the patient tolerates it is what you should do. A couple of slides on measurement. Measurement is really important. This was a study done a few years ago. What they did is they took medical students at a conference and they asked them to check their blood pressure. And only 1 out of 159 students measured the blood pressure properly. Now, I'm lucky that they chose medical students, because I'm sure if they would have chosen us, if they would have chosen consultants, attendings, we would have been just as bad. In the clinic, I don't measure blood pressure. And this is a really nice study which looks at all the effects of the things you can do. For example, if the patient has had tea or coffee, just before you measure their blood pressure, it may be higher by about 20 millimeters of mercury. If their bladder is full, similar kind of effect. Depending on the position and technique, right? Is their back supported? Are their feet flat on the floor? Are their legs crossed or not? That can have an effect of 4 to 25 millimeters of mercury. Whether you're hearing, the observer's hearing is good, whether you're rounding the 0 to 0 or 5, those things can have an effect as well. So there are different ways to look at blood pressure measurement aspects, patient factors, observer factors, procedural factors, and we have talked about better blood pressure measurement for long. But one way to get out of some of these errors, now, of course, the automated machines will not tell you if the patient's bladder is full or if they have had coffee or tea before. But the automated machines take out a bunch of those errors out, and just showing one, right? So this was the first study from over a decade ago, which showed that the first blood pressure was 147, but proper blood pressure measurement brings it down to 133, giving an average of 136. So just over time, repeating measures brings it down. And it's not that you can just subtract 13 or 11 from the first blood pressure measurement. There is an error bar. So this is from Rajiv Agarwal, who looked at, this automated blood pressures versus a casual blood pressure. And yes, the difference was about 12-13 millimeters of mercury. But the limits of agreement, it could be as high as 46 to as low as 21 below the actual numbers. So, there is a wide spread. And really, all the trials have been done using a proper blood pressure method. So if you don't use those standardized, what KDIGO calls standardized blood pressure, you can't really apply the guidelines, because the guidelines are relying on the trial. So you should measure blood pressure the way it was done in those trials. And because of that, you have to work out the logistics. If you don't have a separate room for measuring blood pressure, you can do it in the waiting room, right? Put up a blood pressure kiosk in your waiting room, a slightly quieter area, maybe put a curtain there and measure it there. If you're doing it in the same room, while you're looking at the chart, while you're looking at the numbers, make sure the blood pressure is measured quietly. And if you don't measure it properly, I'm not sure what you're treating, because the numbers can be really anything. Now, you could say out of office blood pressure measurement. I love doing ambulatory blood pressure monitoring. I don't know how popular it is in Telangana, but I think it should be practiced way more widely, because ABPM gives you assessment of the overall load, nocturnal dipping, variability, and so many other things, right? You can decide if the patient has got white coat effect, in which case you will not treat it, or if they have got masked hypertension. In CKD, masked hypertension is extremely common. Anywhere from 30, 40, 50% of patients may have masked hypertension. So we often miss that diagnosis because we don't do an ABPM. Or of course, you could do home blood pressure monitoring, which is the other option. It's kind of a poor man's ABPM, though it doesn't tell you enough about nocturnal hypertension. Anyway, enough about measurement. I'm passionate about measurement, so I have to talk about it, whatever be the topic. In terms of rational medication use, outside CKD, we talk about AC/DC, not the rock band, but, using ACE inhibitors or ARBs. dihydropyridine calcium channel blockers, and diuretics. My preference, of course, is for longer acting diuretics such as chlorthalidone or indapamide and not hydrochlorothiazide. And of course, you could say, hey, what about the DCP trial, which came out last year, and it showed that hydrochlorothiazide and chlorthalidone were very similar in terms of blood pressure effect. And yes, if the patient's blood pressure is controlled on hydrochlorothiazide, there is no need to change to chlorthalidone or indapamide if the BP is controlled. But if not, switching from the same dose, maybe 12.5 of hydrochlorothiazide to 12.5 of chlorthalidone actually is a dose increase. And in CKD patients, you don't have the issues with hypokalemia that was noted in the DCP study. Just one line on non-adherence is that you may think that your patient is taking your pills, but often they are not. This is a really nice slide that shows the effects of adherence. What this shows is the blue line is the number of patients who are taking the pills. And as you can see on day 1, 5% of patients drop off the adherence. That means 5% of the patients take your prescription and they throw it in the garbage. They don't even fill the prescription. This is not uncommon. And over a period of the first few months, you will see that the number of patients who are taking your prescriptions drop. And this is because, let's say, they don't understand the importance, right? They see, I'm taking the pill, I don't feel any difference. It's not like a painkiller where, the pain goes away after you take ibuprofen or what have you. Or they have some side effects, right? They take amlodipine, their legs swell up and they say, oh, this is not giving me any benefit. It is causing side effects. I will stop. At any given time, the difference between the blue line and the red line is somebody who forget to take the pill on a certain day. So about 10% of patients on any given day forget to take their pills. And what you will see at the end of 1 year, about half the patients have stopped taking whatever prescription you're given. And don't think that you are, special or an expert and your patients take your pills. This happens all across the board for most chronic therapies, and cardiovascular especially. And this was one effect. We used direct observed therapy. We had a patient who was on 8 pills and her blood pressure was still 180 over 110. So we brought her to the clinic and we gave all her blood pressure pills and see this effect, over 1 hour, her blood pressure dropped to 90. This is not uncommon. And this is not easy to diagnose, right? She was filling her prescription. She just wasn't taking those pills. So this is something you do need to pay attention to, especially once you're adding pills and you're seeing no effect, think about non-adherence. Now, again, why, let's go back to CKD. Why should the blood pressure be 120? Why should the target be 120 according to KDIGO? This was, of course, the SPRINT trial, which showed that there was a 27% all-cause mortality lowering with a lower blood pressure aiming towards 120. And if you look at the subgroups, they did have about 2,500 patients with CKD in whom they saw a similar effect, right? So the all-cause mortality effect was about 30% lower, 28% lower with a lower blood pressure. So it's a really strong reason why up to GFR of 20, we should be aiming for a blood pressure of 120. And cardiovascular death was even more, 43% reduction. But in severe CKD, this is, once you go below GFR of 20, how do you lower the blood pressure? Blood pressure medications have side effects. If you give amlodipine, they get leg swelling. You give them chlorthalidone, they may get hyponatremia. You give them ACE inhibitors, their creatinine goes up. Is 120 really the right target? What outcomes are you going for? Which patient should you be targeting? When should you be aggressive? When should we back off? And to be honest, in this kind of a population, it's what we call the Wild West, right? We really have no evidence. If you look at SPRINT excluded patients with GFR of less than 20, those are the patients as nephrologists that we see the most. If you look at diabetes, there was no trial that has been done for blood pressure, even for GFR of less than 45. And guidelines, as I've shown you, guidelines say all sorts of things. The Freely Filtered podcast, we discussed the KDIGO guidelines, and even among our group, there was no consensus on whether we like the KDIGO guidelines or not, right? So there was a lot of discussion about how aggressive these guidelines are. And again, going back to what your patient wants. So in this graph, the orange is the number of patients who are going to develop kidney failure over the first 5 years after following a CKD diagnosis. So many patients with CKD will actually die of something else, either with cancer or with cardiovascular disease. So when you are treating blood pressure in CKD, you are not necessarily, yes, ACE inhibitors, yes, SGLT2 inhibitors will reduce risk of kidney failure, but overall you're reducing their blood pressure mostly for cardiovascular risk. What are the medications that do work at this level of GFR? So a myth has been that thiazides do not work with severe CKD. This study from Rajiv Agarwal and colleagues from Indiana showed that that is not true. In this case, chlorthalidone reduced blood pressure by about 11 millimeters of mercury compared to placebo. it was not without side effects, right? So if you look at, this was of course increase in creatinine was 9 times higher. But if you look at hypokalemia, it was higher. If you look at hyponatremia, it was higher. So it is a potent blood pressure lower. It's not a homeopathic drug. It does lower blood pressure, but it does come with side effects. So you have to use it carefully. Now, what else can you use in patients who have chronic kidney disease? One thing that happens is that, you put them on an ACE inhibitors on an ARB and their creatinine goes up, and then people stop ACE inhibitors or ARB. But this is a really important aspect, is that when you see the creatinine go up, and again, I don't need to necessarily tell this to an audience of nephrologists, but you will see that there are things we do that cause the creatinine to go up. For example, in heart failure, when you're diuresing the patient, when you start an ACE inhibitor or an ARB, when you start an SGLT2 inhibitor, you will see the creatinine go up, but these patients actually have better outcomes. On the other hand, if this happens like spontaneously, right? Someone has cardiorenal syndrome, someone has sepsis, they get nephrotoxins, that is spontaneous AKI. So that is true AKI. But this induced AKI is really, it should not be called AKI, right? So Steve Koka, who coined this term, he said it's not AKI, it's hypercreatininemia. And we should just take a deep breath and let it be, right? Don't worry about that creatinine. It doesn't mean there is kidney injury. If we look at tubular injury biomarkers, it doesn't matter. So if there is a strong indication, right, if someone has proteinuria, if they have heart failure, please do not stop the RAS inhibitors just to make that number look better. Patients may worry about their creatinine number, and it's our job to tell them to take a deep breath, reassure them nothing is wrong, they are taking a good pill. And this was, of course, the STOP ACE trial, which showed that, right? So the large trial done in the UK, they showed that if you stop the ACE inhibitors, it doesn't it doesn't decrease the risk of kidney failure. In fact, it was favoring those in whom ACE inhibitors were continued. And if you look at MACE, there was, though the p-value was 0.06, there was a reduction in MACE if you continued ACE inhibitors or ARB about 9%. So continuing ACE inhibitors on ARBs is beneficial in patients with severe CKD. And I know alpha blockers are very, very popular. I remember in my training, we used to use prazosin all the time because it's a very easy drug, right? It doesn't make the creatinine go up. It doesn't cause hyperkalemia. It doesn't cause hyperglycemia. It doesn't cause hypokalemia, but it does cause hypotension. It causes orthostatic hypotension. We did this study a few years ago. What we showed is that the risk of fractures and fall, especially in the older patients, actually goes up. And it's something people don't correlate, right? People have hypotension, they fall for all sorts of reasons. But there is no benefit by giving alpha adrenergic antagonists, and there is harm from giving alpha adrenergic antagonists. So, you have to be really careful about using these drugs. And lastly, I love always to talk about flozins or SGLT2 inhibitors. We think about them as, glucose lowering agents, but they also lower blood pressure. At least 4 over 2 millimeters mercury, and depending on the hyperglycemia level, people who has blood sugar is high, their blood pressure effect that you will see is way more than what you will see with other drugs. So and these drugs can be started down to a GFR of 20, and I even start them below a GFR of 20, but their benefit continues even after the GFR drops below 20. So don't stop them if the GFR drops below 20. So you can get some added blood pressure lowering effect by adding flozins. But you should know when to bail, right? So this was Amit Langoti, who was a former fellow of ours. Now he's in Mumbai. He put this figure out. So many CKD patients will have stiff arteries. And this is very common. So, a wide pulse pressure is showing that. And their central blood pressure may be not what their peripheral blood pressure is showing. And for more on this topic, we had Dr. Remy Gopal, who presented Grand Rounds. It's available on our YouTube channel. We still don't know what to do in these sort of situations. It's a difficult situation, but don't drive blood pressure down if the patient is not tolerating. And just to belabor this point, even in sprint, they could not get everyone below 120. And factors that were associated with a failure to achieve that 120 blood pressure was CKD was one of them. So if the patient was older, if they started off with a higher blood pressure, but if they had chronic kidney disease, it was harder to get them down to 120. So when you have a patient with CKD and you cannot get 120, don't feel that you're a failure. Even in the largest blood pressure trial of sprint, they could not do that. And side effects are way longer. So, and at really low GFR, when it's, close to 10, you're thinking about dialysis and transplant, it's okay. All right. You're allowed to use second line and third line drugs in this situation. Maybe stopping the ACE inhibitor will buy you some time to get the fistula to mature or to get the PD catheter. And in those sorts of situations, for a few months, it's okay to stop the ACE inhibitors or ARBs. I'm not saying never stop them. I'm just saying that if the creatinine goes up, try to continue them. So just to summarize and finish on time, my suggestions are that it's really about shared decision making. It's not that you saying, oh, the blood pressure has to be 120 or it has to be 140. Understand your patient's goal. For an older patient who doesn't have proteinuria, the risk of dying may be higher than the risk of kidney failure, and understand that that is why you're treating their blood pressure. Most importantly, be brave. Continue ACE inhibitors and ARBs, especially if the patient has heart failure or proteinuria. It's really going to be very, very important in those sorts of situations that you're going to get benefit by continuing RAS inhibition. Don't panic if the creatinine goes up. Chlorthalidone, indapamide, hydrochlorothiazide, thiazide diuretics can be used. The big problem, of course, is not hypokalemia in CKD patients. Often it's hyperkalemia. So these drugs are in fact useful for treating hyperkalemia, but you will often see hyponatremia. So that is a tricky part. And if you get hyponatremia, you often have to back off. But if not, these drugs should be used more commonly. And the lowest tolerated is very important. So, even if you can't achieve 120, if you go from 150 to 140, it is still useful in reducing cardiovascular risk, right? The aim is to lower the blood pressure to as much as the patient can tolerate, not to, reach 120 or 130, whatever the guidelines say. Try to lower the blood pressure as much as you can with whatever therapies you have, making sure to back off if there are adverse effects. And never forget, you can always fluosinate. So with that, I would like to thank everyone. As you know, I'll give a plug to the Freely Filtered podcast, as well as the NFJC Twitter chat. In May, we will be discussing the KDIGO guidelines, the 2024 CKD KDIGO guidelines. And I hope some of you may be able to come and visit Ottawa. It's a beautiful city. This is the capital of Canada, and that's the Parliament Hill there. And I will stop there and see if there are any questions or whether we need to go to the next talk.
Yeah. Thank you, Dr. Swap, for that wonderful basic discussion on hypertension and kidney disease. I would like to say a few words. How can you say that kidney is the villain in hypertension rather than the victim? Because most of us believe that, and public also believe it is a cardiac disease. So we should be able to tell our residents that kidney is the primary organ responsible for at least primary hypertension. So how can you say a few words on that aspect?
Yeah, I didn't go into the patho.
Responsible for primary hypertension.
Exactly right. I didn't go into the pathophysiology, of course, in the interest of time. But you're right. That often, especially in places like India, salt is a huge component. And it is how the kidney handles salt that is contributing to hypertension. It's the, Guyton has this nice physiology about thresholds of sodium excretion. And that is probably a primary culprit of the cause of hypertension. And as you rightly said, the term should be primary hypertension and not essential hypertension. Exactly. So it's the kidney, which is, again, some people may say it's not even primary because the kidney is at fault. But absolutely right. The kidney is in most cases of primary hypertension, it is the kidney that is at fault. And nephrologists should own hypertension, not cardiologists.
Good evening. This is Dr. Chakravarti from Hyderabad. Thank you for a very nice talk. Though most of the thing, as you said, is known to the audience, you put them in proper perspective and you covered a lot of mileage in this short time. Thank you for that. And excellent slides conveying whatever you wanted to convey in a very crisp way. I have I don't know if it is a comment or a question. So you showed us your beautiful city of Ottawa. We are in beautiful city of Hyderabad. Today, the temperature is 42 degrees or 43 degrees. Do you think it is justified to add a diuretic to hypertensive regimen in a city like Hyderabad?
It's an excellent point. And you should be a better expert on this topic than I am.
Oh.
I grew up in Mumbai, and I remember growing up, I in fact, I didn't even have a sweater when I left Mumbai to come to Ottawa. And here we have minus 20 degrees. Right now, of course, it's 15, which is very pleasant. So you're right. Again, it depends on the patient's volume status, and you're probably likely to get way more side effects with thiazides, especially, and you will have to be cognizant of the season. right? So in the summer, you probably may need to back off compared to the winter on your diuretic dose.
So my bias has been not to use at least a stiff dose of diuretics. If you look at the guidelines now for CKD progression, you put them on ACE or ARBs, you put them on SGLT2, you put them on Finrenone, and then you add a diuretic for them. And they live in Hyderabad. Invariably, they will come with a very high level. And I fully agree, inducible AKI is different. But we have patients who come with 4-5 creatinines, their baselines being 1 point something. So at those times, we do take off one by one the drug and try to bring the creatinine down. I think guidelines are formed in cold countries, and they are used in very, very hot weather.
Yes.
So that is something that we need to keep in mind. Yeah. Thank you so much.
Yeah, that's an excellent point. Yeah, I agree.
So Dr. Swapnil, excellent presentation. And so only thing is I found the beta blockers and the clonidine missing in your presentation, which is very often used here. And then spironolactone, which is again, I mean, the go-to drug for refractory hypertension, hyperkalemia is always there. So how frequently do you use clonidine in your practice?
Yeah, so we do use beta blockers and clonidine, second line drugs. Again, I didn't go there because I know these are used. My point was to encourage using drugs that people perhaps might be afraid of using. Clonidine is short acting. That's the only thing to remember. So you have to give it, 2 or 3 times a day. There are other preparations in Australia. They have this moxinidine, which
We
is
have
really
that as
long
well.
acting.
Yes.
Yeah, so
Available here
moxinidine,
also.
It's available here.
exactly. Yeah, I would again, if the cost is not a concern, I think moxinidine would be better, because with clonidine you can have the rebound hypertension, right, as the effect wears off. In the US, they have a clonidine patch which can go on for like a week or something. But a longer acting clonidine preparation, that would be fantastic. I think that would be really useful. Again, the thing why clonidine, beta blockers, we don't talk about that is because there is no end organ benefit that has been demonstrated, especially for these drugs. Hopefully, no one mentioned hydralazine. Hydralazine is even worse. But yes, when you're struggling, these are excellent drugs to use.
Okay, thank you. Thank you very much. And ABPM here also we are using, but not routinely. So now the thing is, we have a significant proportion of white coat hypertension in India as well. So what do you do for these patients? I mean, you are saying that most of us don't see the blood pressure, some assistant sees it, but now the guideline says the patient should see his or her own blood pressure without the presence of a doctor, and they should use an automated machine. So how far do you believe in that? I mean,
Yeah, so we do.
we should
Yeah.
see.
Yeah, go ahead.
Yeah, please. Yeah. You
Yeah,
can
so
ask.
the ABP, yeah, the white coat, if you have confirmed that they have white coat, then there is no need to, you treat what their that blood pressure is, and not the higher blood pressure that you're seeing when you're looking at them in the clinic. I think masked hypertension is just as important to detect.
Yes.
A lot of our patients may have masked hypertension, especially in CKD, and the risk there is under treatment. So that is really, and once you start doing ABPMs, that's when you pick up that, oh, these patients have blood pressure that is even higher outside, maybe their home life is stressful, right? Maybe their work life is stressful, and that blood pressure is higher. But if it's clear-cut white coat, we don't treat them. The unattended blood pressure measurement is really important. It is very hard to do, right? It takes time. But if you can figure out the logistics of how to do it right with those automated machines, that is worthwhile, because you get a really good number that you can rely on. It takes an extra 5-10 minutes for your patient visit and some, juggling of how your room is set up, waiting room is set up or something. But I think if you can do it, it's definitely worth it to spend that extra time getting that proper blood pressure measurement.
Okay, thank you. Thank you very
Swapnil,
much.
an excellent talk as usual. I think it's been great listening to you. Just a question from my end, if the host allows me. I know Swapnil is also on hurry to leave, but how often are you able to achieve the targets of 120 systolic in your clinical practice, which in fact is definitely a challenging task for us from this side. Having the guidelines based on a single RCT, we understand it's definitely challenging, but do you do it practically, and what are the implications of the same?
Yeah, I'll confess, I don't
Practically,
always.
I mean, what I'm saying is real world practice. Yeah. Swapnil.
Exactly. The thing is, if you do an automated blood pressure monitoring, your success rate goes up. just because you're doing it properly, right? So that is one
Correct.
secret, is that you measure the blood pressure properly. Like average will go down by about 12, right? So that will improve your success rate a little bit. But I agree, it's not, it's far from 100%. I think I'm barely touching 50% of my patients getting down to 120, especially in the older patients. So again, it's your intention, right? It's your intention that matters, that you're intending to lower the blood pressure. Especially if I'm looking at, somebody who is on 10 milligram of amlodipine, 25 of chlorthalidone, 32 milligrams of candesartan, and I'm adding, I've got 25 milligrams of spironolactone. And now it's like, oh, I have to add them clonidine and bisoprolol to get them from 132 to 120. It's at that time I say, hey, is this worthwhile, right? So you have to talk to your patient and say, hey, I think we have done the best we can, and it's okay to sit tight at that level, as long as you have made a good effort. It's not that they are just on 2.5 of amlodipine and you say, oh, I'm done. There are, as long as you have tried everything that you can, that's sort of the intention, that try to go. Even in sprint, the average blood pressure was 123 in the intensive blood pressure arm. So they could not get down below 120 overall. So even in sprint, they had less than half the patients who could get down to less than 120.
So practically, you don't aim to come down to exact figures of 120 and all this. We just see to it that it is optimized. And of course, as you understand, it's very difficult for us to have the accurate measurement in OPs of ours, which is humongous and huge in numbers. Anyway, thank you. Thank you, Swapnil. Thank you so much. Over to
Thanks for having me.
from the host.
Yeah. Thank you, Dr. Swapnil, and thank you so much for accepting to be today on a busy morning. Thank you so much. Amidst of you had a busy WCN, but despite that, you have accepted to be with us today to share your bright insights about the treatment of hypertension in CKD. Thank you so much, Dr. Swapnil. Thank you, chairpersons. Now we move on to the next case presentation. We have from Dr. Chiranjeevi, who is resident from Osmania Hospital. To chair the session, may I invite the chairpersons. I invite Dr. Swarnalatha, who is professor at Nizam's Institute of Medical Sciences, and Dr. Namrata, who is additional professor at Dr. Ram Manohar Lahotia Institute of Medical Sciences, Lucknow.
So, good evening. I think it's been very interesting to listen to Dr. Swapnil, and he had very crisply and clearly read the message of the BP measurement, the target, new target, and how to achieve it. So now let's move on to the interesting case by Dr. Chiranjeevi. He is a resident from Osmania Medical College, Department of Nephrology. We'll be talking on the intriguing case of hypertension in an adult. So let us listen from him, and then probably we can take few questions after that. Namrata, you want to add something?
No, ma'am. No issues.
Okay. So I think Chiranjeevi, you can start the presentation, and we will have discussion after this.
Good evening, everybody. Respected chairpersons, all
Your
faculty.
slides, you can upload your slides.
Yes,
Share
ma'am.
your slides.
Yes.
Can you put in slideshow mode, Chiranjeevi?
Yes, ma'am. My screen visible, madam?
Yeah, it's visible, but some black patches are coming. Yeah, I think move to the next one.
So I think meanwhile, Namrata, can you just add on your use?
I'm really looking forward to seeing what this case could be. Generally, whenever people present interesting cases, we see renal artery stenosis as a very common entity being discussed. So I'm really looking forward to see what could be special about this case.
Chiranjeevi, can you
it'll be
move on
good
to the
to
next
see.
slide? Can you move
Yes,
on?
ma'am.
Yeah, you can
Yeah.
start.
Yeah, right. Yeah. Please go
Good
ahead.
evening, everybody.
Yeah,
I'll be
please go ahead.
presenting an interesting case of adult hypertension. So, Mr. RK, a 37-year-old male, resident of Hyderabad, graduate, software developer by occupation, ex-smoker, in total 2.4 pack years smoke, presented in May 2023 with chief complaints of shortness of breath at rest, NYHA class 4, and swelling of both legs. The breathlessness initially started as paroxysmal nocturnal dyspnea and progressed to NYHA class 4 over last 15 days. It was not associated with any chest pain, palpitations, or fever. Pedal edema was bilateral gradual in onset and up to the ankles, which had progressed over last 10 days. It was not associated with any local rise in temperature or redness. There was no history of recent gain in weight, moon phases or purple stripe, no history of any weight loss diarrhea, no history of headache, palpitation, sweating, tremors, panic attacks, no history of evening fever, cough, expectoration, no history of TB or TB contact, no history of limb weakness or claudication. There's no history of diabetes, obesity, coronary artery disease, or cerebrovascular accidents. There's no history of previous use of any drugs, and no history of hypertension in the family. At presentation, the patient had pulse rate of 120 per minute in right radial arteries, regular in rhythm with increased volume and force, with a radiofemoral delay being appreciated. The upper limb pulses were all palpated. Carotids could be normally palpated. However, the femorals were feeble and distal lower limb pulses were absent. BP at presentation was 280 over 140 millimeters mercury in right brachial artery in supine position. The left upper limb BP was 268 over 132 millimeters of mercury. The lower limb BP could not be measured. There was pedal edema. Facial puffiness was present. There's no xanthemas, no carotid bruit or tenderness. Cardiovascular examination was normal. Respiratory system, bilateral post-crepitation over both lung fields. Air entry was equal on both the sides. Per abdomen, we could appreciate a renal bruit which was systolic diastolic on left side around 5 centimeters superolateral to umbilicus, and also the same could be appreciated over left renal angle. Fundoscopy was done, which was suggestive of bilateral grade 4 hypertensive retinopathy. The provisional diagnosis based on history was hypertensive emergency, pulmonary edema, acute kidney injury, refractory hypertension, and to rule out the renal cause of hypertension, probably Takayasu arthritis. The investigations at presentations, creatinine was 6.4, urea was 170, sodium 140, potassium was 3.3 milligallons per liter, RBS of 88 milligram per DL, LFTs were normal, hemoglobin 11.1, TLC 6,000, platelets 3,30,000, ESR was 120, and CRP by qualitative fit test was positive. CUV was suggestive of albumin of 2+ with no significant RBCs or WBCs. UPCR was 1. On USG KUV, the kidney sizes of both the sides were normal and the CMD was maintained. ECG was suggestive of left ventricular hypertrophy along with tachycardia related STT depression. Further coercing ward, as the patient was found to have creatinine of 6.4, patient was initiated on hemodialysis in view of acute pulmonary edema and uremia. Overall, 14 sessions of hemodialysis were done during hospital stay. During that stay, patient had 3 episodes of flash pulmonary edema. Also, patient had difficult to control hypertension. In view of same, patient's antihypertensive drugs were slowly escalated. Initially, the patient was started on nifedipine extended release 20 milligram BD, which was slowly increased to 60 milligram BD, along with injection furosemide 60 milligram BD dose in view of volume-related symptoms. This was further escalated by adding carvedilol extended release 10 milligram OD, the dose of which was eventually limited by bradycardia. Furthermore, we had to add prazosin 10 extended release 10 milligram BD. The dose was limited by postural symptoms. To add to that, next we went to clonidine 0.2 milligram TID. The dose was again limited by postural symptoms. Further, minoxidil was added 5 milligram BD. This was tapered off after adding isolazine later on. A spironolactone 25 mg BD had to be added in view of refractory hypertension, and the patient also had recurrent episode of intradialytic hypertension. So the spironolactone was added in view of the same. Later on, as the volume symptoms improved, volume status improved, the patient was switched to oral furosemide. BP control was achieved with these 7 simultaneous antihypertensive drugs. Most of the drugs could not be escalated to full dosage in view of limitations by side effects. As mentioned, patient had 3 episodes of flash pulmonary edema and hence was taken up for renovascular workup. The renal Doppler study was as follows. Peak systolic velocities on right was 69 meter per second, on left was 80 meter per second. Acceleration time was 315 milliseconds on right and 110 milliseconds on left. Resistivity index was 1 on right and 1.25 on left. There was reverse diastolic flow present on both the sides. The impression from the radiologist was to rule out renal parenchymal disease versus renal artery stenosis. Carotid Doppler bilateral on both the sides were normal. Lower limb Doppler was done, wherein the common femoral, superficial femoral, popliteal artery, anterior tibial and posterior tibial artery showed normal color with Parvus Stardust waveform on right side, and posterior tibial and anterior tibial artery showed decreased velocity on the left side. A CT aortogram was done, which was suggestive of complete occlusion of abdominal aorta after origin of superior mesenteric artery, circumferential thickening of abdominal aorta from B2 to L1 with stenosis of approximately 60 to 70%. Both external iliac artery and internal iliac arteries were formed by multiple collaterals, and the SMA was supplying small as well as large bile. Similarly, bilateral renal arteries were formed with multiple collaterals from lumbar arteries. So the final impression was features suggestive of aorto-occlusive disease with thrombotic occlusion of abdominal aorta with a suspicion of vasculitis. These are the images. We can clearly appreciate the aortic cutoff. On the left side, we can see a contrast angio image. Similarly, on the right side, we can see the 3D reconstruction image wherein we can appreciate the aortic cutoff as well as multiple collaterals. This is the maximized view. We can appreciate the aortic cutoff. The 2D echo was suggestive of concentric LVS and grade 1 diastolic dysfunction, the normal ejection fraction. The ambulatory BP charting was suggestive of absence of nocturnal dip. Sputum for AFB and CBNAT was negative, VDRL was negative, and APLA profile was negative. A diagnostic criteria for Takayasu arthritis was applied, which was suggestive of a score of 7 by 10, wherein score of more than 5 is suggestive of Takayasu arthritis. We came to a final diagnosis wherein the hypertensive emergency was resolved, pulmonary edema was resolved, refractory renovascular hypertension controlled on 7 antihypertensive drugs, acute kidney injury resolved, status was 14 sessions of hemodialysis, aorta-occlusive disease, secondary to Takayasu arthritis. At follow-up, the patient was started on prednisolone 1 mg per kg and methotrexate 15 mg per week in a consultation with rheumatology. The prednisolone was gradually tapered. Then, following this, patient had sudden onset of oral ulcers and fever. LFT and CBP were normal. A clinical diagnosis of methotrexate toxicity was made, and the patient was treated with injection leucovorin. The patient improved, and the acute symptoms resolved completely. Further, the patient was shifted to mycophenolate mofetin as per rheumatologist advice. The patient is currently maintained on mycophenolate and low-dose prednisolone. Is currently doing well with a hypertension control to a baseline of 140 over 80 millimeters of mercury. And as the volume status has improved, has got better, the patient is shifted now from furosemide to oral hydrochlorothiazide. A comparative chart for the investigation, the creat has settled down to 1.24, potassium is 3.6, ESR is normal 30, CRP is negative, and hemoglobin is 14.1. Thank you.
Thank you, Chiranjeevi. It's really an interesting case, though rarely we encounter such patient, but I think it's really difficult to manage such patient. So coming to the diagnosis, there is no definitive diagnostic method, but based on the clinical immunology, there is certain criteria given by the Rheumatological Association. So it's not difficult to really diagnose such cases, but what matters is the management. Particularly, I think this patient had extensive disease, particularly aorta was cut off, and then bilateral renal artery stenosis with an AKI. So one is, of course, the pharmacological management you have managed it very well. The second challenge is when to go for with surgical endovascular or the open surgeries. So, and the third point is, as we have mentioned, that patient was started on the disease modifying drugs, methotrexate and MMF. So, how long to continue and when to how to assess the disease activity and whether there is definitely an indication of this disease modifying drugs, particularly with the background of the what you mentioned about the complications, infective complications. So these are the challenges. I think it was well managed, and I would request my co-chair to comment on this, please.
Overall, very well presented case also, Dr. Chiranjeevi. Done a great job. Overall, I think Takaysu arthritis, what we commonly see as nephrologists is as resistant hypertension and with some degree of renal failure. To be seeing this patient who has presented as AKI, that is something which is quite rare. So we have a rare presentation of a not so common disease. So that in that scenario, making a diagnosis of Takayasu, yeah, you've done the job well. Secondly, one more issue is that how do you monitor this disease? There are some older, review articles, etc., which tell you that Takayasu ought to be managed with, regular CTs or MRIs or whatever. How do you plan to manage your patient's disease, considering it's an extensive disease in the aorta?
Ma'am, actually, we had a discussion with a rheumatologist and cardiologist with us. So we plan to continue the immunosuppression and monitor the inflammatory markers for this patient, as well as continue a low dose aspirin for this patient, so that we do not give a chance for that thrombosis to extend or worsen. So with the CRP and ESR, since we can clearly see that the inflammatory markers have responded quite well to the immunosuppressive therapy, so we plan to monitor ahead with that.
So actually,
So,
Dr. Namrata, your comments are very valid. So now you have ACR guidelines for monitoring of Takayasu's and also. Generally, they say, as you rightly said, that they ask for repeat imaging. So actually, that
Yeah.
is a major challenge. But so now many guidelines do say that we can monitor with the blood markers. And some studies have even suggested guidelines also doing PET scan for monitoring of the inflammation of the vessels. So doing repeated CT angios is difficult. I mean, it's not an easy task and all that. So practically what is done generally is monitoring with the blood markers, and the therapy generally goes on for a year. After that, it is tapered. So that's what is
tapered
done.
off.
Yeah. So in case this patient responds and does not go into any stenosis, anyhow, collaterals are also there. I mean, some sort of collaterals are also there. And if the hypertension is well controlled, and the renal failure is not there, probably we may manage him conservatively with the medicines, try to taper off some of the antihypertensives. But if he continues to require multiple antihypertensives and balancing them is a problem, and the disease enters the quiescent phase when the inflammatory activity is not there, and if the renal functions deteriorate, at that point of time, we may plan doing any sort of intervention, either a plasty or a stenting with a plasty. So most of the studies have shown that medical management is good enough, provided the patient is comfortable, the hypertension is well controlled on minimal medicines, and there is no worsening of the renal parameters. So that's what probably we are planning to follow. And this patient has a thrombus as well. So we have had multiple reports of thrombus with Takayasu's as well. And the other interesting thing is, like you pointed out yourself, many of the Indian patients, they present with hypertension. I mean, that's the usual presentation. And the other important thing is that most of the Indian patients, we have this abdominal aorta involvement
Abdominal
quite
disease.
common. It's quite common as compared to others. Bilateral disease is also reported, bilateral renal disease in Indian patients. So around 70% of them have bilateral renal disease. So Indian Takayasu is, in fact, a little bit different from what we see in the West. It occurs in roughly in the third decade. And the other important thing is that the Ishikawa criteria, and there are other older criteria which may not fit the Indian Takayasu. So we have to look at the iliac vessel involvement, all those things which may not be present in others, but may be found in India. So all those things are very, unusual features for Indian Takayasu. But yeah, over a course of 1 year, probably we may see 3 or 4 cases. I mean, it's not that common, but we occasionally see it and we shouldn't miss it, because whenever there is, so the most important message is severe hypertension, young hypertension, and if there is asymmetry of pulses, because many of the times we do not put our hand on the pulse, or if we do it only in one limb, and despite telling everybody, we ourselves sometimes don't measure four-limb BP. So generally it's a clinical pickup at bedside, which should never ever be missed. And renal bruit, yeah, many of us, so renal bruit, four-limb BP, and the pulses. I think if that is done, most of the times the diagnosis is clinical. So
Yeah, it's good to pick it up clinically, ma'am. As a disease, it's very well
Absolutely.
taken. But what happens is there are so many other scenarios where we just see hypokalemia, say some amount of metabolic alkalosis, and we
Yes.
look for a secondary hypertension in those cases. I would just like to know from the house as to how common is it for people to do a PA-PRA ratio in such cases. I don't see that many people are enthused to do that, as well as the fact that, you know, the blood pressures are already difficult to control on a variety of drugs, and it becomes sort of tedious to be doing PA-PRA ratios.
So
But
excellent question. So if we have this asymmetry of pulses and blood pressure, I mean, difference in different limbs, we do not at the onset send off these ratios because they are not available in-house. But whenever these things are not there, difficult to control hypertension and hypokalemia, we get it done in all such patients, because endocrine hypertension, we should never ever miss, neither the FeO nor the CONSA. I mean, they are also very important causes. But whenever we have a peripheral sign, for example, a renal bruit and a systolo-diastolic bruit, which is quite specific, renal bruit and asymmetry of pulses, in such cases, we first look for Takayasu,
Yeah,
do the imaging and all
sure.
that, and keep the other things on hold. So that's what our practice is. So what do you do at your center? Maybe do you send all of them at a go?
No, ma'am. Even we don't do that because again, it's not in-house in our hospital as well. And number of patients who are actually ready for an expensive investigation out of hospital is obviously not so common in a government setup where I work. No other questions from my side, and thank you, Dr. Chiranjeevi, for the presentation. Swarnalata ma'am, on to you.
Yeah, Manisha, I have one query. Like you said, surgical intervention, probably you might consider in future when BP is not under control, or there is the worsening of the kidney function. But here I see that patient is already aorta cutoff is there.
Yes.
But the whole abdominal aorta is all involved. So if at all it's required, what surgical intervention or endovascular procedure is recommended?
Yeah, so the thing is, suppose in case this patient, I mean, right now, patient is comfortable, blood pressure, drugs are coming down, renal fail, so it's fine. But presumptively in future, if there is uncontrolled hypertension and renal functions and all that, so what we have done, in fact, we have published such a case where the ostial involvement was there, the distal renal artery was intact, so that patient underwent a lieno-renal bypass. So, I mean, though the aorta is, involved, so that renal artery in that patient, similar presentation. So what we had done was, one of our surgical gastroenterologist, he had done a lieno-renal anastomosis, lieno-renal bypass. So that brought down the hypertension. On the left side, lieno-renal can be done. On the right side, hepatorenal. Finally, I understood with whatever limited experience of, I think I have seen around 23 cases of Takayasu's. So 4 or 5 underwent a surgical intervention. And in one of the cases, the kidney was removed, some sort of autonephrectomy was done, and it was placed to other segment of the aorta, which was relatively normal. But all this was done when the inflammation had subsided. There is no point in doing it in a friable aorta. So one thing I understood, it's mechanical engineering. I mean, wherever there is a good segment of aorta and you have a distal renal artery, at least some distal renal artery should be there, which is patent, which can be anastomosed. So this you can find in one of the publications in JAPI about lieno-renal bypass, which we had done, I think that was around 15 years ago, and the patient did very well. So sometimes it may not be possible at all if nothing is, so in one of the patients, I read in one of the articles that they have done the renal artery with a synthetic graft. They have anastomosed it to the thoracic aorta because the abdominal aorta was all involved. So these things are also done.
You can identify a segment which is not involved.
Yes,
and then
absolutely.
Absolutely. Auto transplantation.
Auto transplant, yes.
Convince our surgeon, that's the most difficult part.
Absolutely.
ESR is a very non-specific. So now newer biomarkers have come, like what you call the inflammatory markers or the anti-endothelial antibodies.
Yes.
So is of, monitoring the disease activity through this? Is it like feasible, or you can just, go with only ESR?
Yeah, so these are described by Indian authors also, anti-endothelin antibody, as you rightly said, then CD8 plus cells, all those things have been described, but none of them is mentioned in the guidelines as, they are not validated for monitoring the disease activity. Simplest still remains the ESR and CRP. So that's what has been mentioned. So as of now, they have not come into the guidelines, Vanata, but your question is really good and futuristic. But as of now, we stick to the traditional markers. That's what the guideline says.
A quick comment. Chairpersons can allow. There are Euler guidelines, Manisha. I'm not sure if you've gone through. The contrast enhanced ultrasound can be used as, the methodology for monitoring, whatever, surveillance or monitoring or whatever it is. Of course, the biomarkers. But there are guidelines with respect to the imaging modalities. And then PET-CT, as we all understand, PET-CT, it's difficult for us to use it as a surveillance tool because exposure is little high. And so MRI can be one. And there is something called, Takayasu index, ultrasound index or something. I'm not getting the name of it.
Sorry. Actually, the light went off. So again, I had to join from this thing. So I think I'm not visible either now. So lights have gone. So yeah, so I heard about contrast enhanced ultrasound.
Let me
Yes.
Takayasu
I
index.
I didn't hear you. Can you repeat the question?
One is Euler guidelines say CUES can be used.
Yes.
Enhanced ultrasound.
Absolutely.
See, we'll
Yes.
not, let's not delve into the biomarkers as such, which is difficult, but then contrast induced ultrasound. The other comment is regarding the PET-CT, which obviously will be grave to the patient if we go on as a surveillance methodology, instead MRI, and then ultrasound based, some indices are there, Manisha. I'm not able to recollect the name of it, but Takayasu index, ultrasound index, something is there, which helps us in measurement of the thickness of the media and intima, and then look at the activity or the edema of the wall, something like that. So these are the measures probably which are available for the imaging surveillance of Takayasu. And of course, the biochemical or, the marker assessment is little different. And then we have also had similar experience of a lady who had the Takayasu, which was there, for whom we had done a splenorenal shunt. Of course, I was not there in Gandhi at that time, but she came for follow-up. In fact, she became pregnant after that renal shunt as well, and she's maintaining her creatinine around 2 to 3 or something like that. So these are the couple of
Absolutely points well taken, Manjusha. So that's what we intend to monitor. As I said, PET-CT. So contrast enhanced ultrasound, PET-CT. So generally the monitoring the guidelines say is radiological monitoring. Many of them are not feasible, but we plan to do a PET-CT for this. Contrast enhanced ultrasound currently is not available with us, and PET-CT can be done. So contrast enhanced ultrasound probably would be a good methodology to follow up, along with the inflammatory markers. In fact, inflammatory markers are all traditional markers, and PET is easily available to us and can be done.
You, Dr.
One question, Manisha. There's an old concept, particularly in tropical countries. Tuberculosis was associated with Takayasu arthritis, and we used to treat all patients with ATT. Once we see a patient with Takayasu arthritis, is it still holds good, or we can get away with that?
No, so as of now, yes. So that's why that CBNAT and all those things were done. And Indian Takayasu, that was reported that association with TB and all that, around 30% cases they've said. But prophylactic treatment without getting any evidence is not recommended. So that's why we don't put the patients on ATT. So this case is being managed along with rheumatologists from NIMS, and they are also of a similar opinion. So that's why you have to check, rule out, but it's not always the case. It's not 100% association.
Yeah, due to want of time, we now end the session. Thank you, Chairperson, Dr. Chiranjeevi. Thank you so much for that app presentation. Moving on, we now have management and approach to hypertension in a child by Dr. Pratima Verma, who is pediatric nephrologist from Rainbow Hospitals, Hyderabad. To chair this session, may I invite Dr. Priya Bas, who is a professor of pediatric nephrology at Department of Pediatric Nephrology at St. John's Medical College, Bangalore. Dr. Anil Vasudevan, professor at St. John's Medical College, Bangalore. Dr. Dhanalakshmi, senior consultant nephrologist from Hyderabad. I request Dr. Dhanalakshmi to introduce the speaker.
Good evening, everyone. I would like to call upon Dr. Pratima Verma, consultant pediatrician and pediatric nephrology at Rainbow Children's Hospital and KIMS Kondapur. And she has completed MBBS from Osmania Medical College, Hyderabad, and postgraduate pediatric nephrology at training at Birmingham Children's Hospital, UK. And she has done an attachment in pediatric nephrology at St. John's Medical College after moving back to India, and she's a member of ISN, ISPN, Royal College of Pediatrics and Child Health, and International Pediatric Nephrology Association. Over to you, Dr. Pratima.
Hi, sorry, can you see my screen? Because I think I got logged out of the Zoom call.
Not yet, Dr. Pratima.
Not yet. Okay, just hold on.
No, we're not seeing your screen, but not your presentation. Yeah, we're able to.
Yeah?
Yes, yes.
Great. And can you hear me fine?
Yeah, we can hear you.
Excellent. Thank you so much, first of all, to for inviting me to this session of Women in Nephrology Telangana webinar. And I am quite honored to share the presentation in front of such an esteemed panel. So coming to the hypertension in pediatrics. So moving on, I just wanted to highlight that, children are not small adults, and therefore, what is the optimal approach that we need to use in children as opposed to adults in making the diagnosis? And once we are confident that we've got the diagnosis correct, what is the recommended workup for a child? How far do we actually look for the etiology of secondary hypertension? Are there any goals that are set to maintain the systolic and diastolic BP against? And are there any tangible benefits of, having a lifestyle that, as well as antihypertensive medications, that can influence any indirect cardiovascular outcomes in children? So coming to the prevalence of hypertension, first of all, is it really, present in the general population in pediatrics? Well, it is definitely present. And looking at the studies that are out there for the last couple of decades, the average prevalence of hypertension is reported as 5%. So almost 5 in 100 children would be hypertensive, out of which, it almost doubles if you're looking at elevated blood pressure, or which used to be a pre-hypertension definition before. So that's almost 10 to 20%. If you're looking at certain subgroups of children, say, for example, in obesity, it's reported to be as high as 29% in some studies. Sleep disordered breathing, sleep apneas, in children who are snoring with big adenoids, again, there is a higher incidence of hypertension, which is reported to be as much as 5 to 15%. We all know about CKD, that almost half, 50% of children with CKD are hypertensive, out of which a majority of them would actually have masked hypertension. So that again is something that we have to keep in mind and astutely look for. Once the child enters the end-stage renal disease phase, almost majority, up to 80%, will be hypertensive. Again, there are good evidence to show that being born premature with a low birth weight, having some neonatal complications, puts you at a higher risk of hypertension, almost up to 7%. Now, also bearing in mind that prevalence prevalence of primary hypertension is definitely almost as much as 10 times more than secondary hypertension. So when it comes to children, we always think, okay, is it secondary? But we also have to bear in mind that the prevalence is more for primary hypertension even in children. Hypertension under the age of 6 definitely would need a thorough look for a secondary cause. Children who present with severe hypertension or in hypertension crisis, obviously for them, it's usually a secondary cause that can be identified. And coming to the trend within urban children, and it's needless to say that urban children have got a higher prevalence of hypertension, possibly because of our lifestyles as well as diet. And again, since the last couple of decades, the trend has been rising when it comes to the prevalence. So once we are all convinced that, hypertension is prevalent in the pediatric age group, what do we do to screen for it? Do we do anything? I mean, what are we doing in our daily practices as pediatricians or pediatric nephrologists? Obviously, for all healthy children over the age of 3 years, there is a clear recommendation that they should have their blood pressure checked at least once per year. However, in those children, who have the following comorbidities like obesity, diabetes, or they are on drugs like steroids or methylphenidate, phenylephrine, CNIs in our case, they would need, a blood pressure check at every health encounter. Needless to say, if they already have a history of renal disease, or congenital cardiac disease, aortic arch obstruction or coactation, they would also need a BP check at every health encounter. Prematurity, again, is another area where we would like the neonatologist to keep an eye on the blood pressures. So coming to screening, in children who are less than 3 years, do they need screening? Yes, in some special situations like those mentioned, they do need screening, especially, highlighting the history of prematurity, diabetes. If we know that they're on drugs, especially ADHD children who are on methylphenidate, they definitely need screening. Again, renal disease and UTIs would need a screening at least annually, if not every visit. Other syndromic children that we come across, say neurofibromatosis, tuberous sclerosis, or sickle cell disease, again, they have a higher incidence of hypertension, so they would need screening too. Now, which guidelines do we use? I think we already heard that there are many guidelines that are in use. And the ones that we generally use here is the AAP CPG guideline from 2017. They are similar to some extent, but they do have subtle differences. So it would have been nice to have a consensus guideline for universal use. But having said that, does one guideline fit all? Probably not. So, the normative data and all are, unfortunately, mostly for Caucasian children, German children. So it is something that we are extrapolating against, but is that the right practice is a question to be still answered, I think. So coming to the AAP CPG guideline, how do we define blood pressure categories and stages in children? So it is defined against the gender, against the height and the age of the child up to the age of 13 years. Beyond 13 years, in this guideline, we are using the adult cutoffs, which makes it slightly simpler actually, because it then rolls on to the American, Heart Association guidelines for adults for hypertension. So the normal blood pressure is classed as less than 90th centile, and elevated BP, which used to be pre-hypertension, is between 90th to 95th, as well as then stage 1 hypertension would be above 95th, but below 95th plus 12. And stage 2 would be beyond the 95th plus 12, or, over 140/90, whichever is lower. So above 13, as you can see, the cutoffs are straightforward, where normal is under 120/80, elevated is 120/129, stage 1 is 130/139, and stage 2 is 140/90. Now, coming to the subtle differences, obviously the American Heart Association, or say the AAP guideline, uses 13 as the single cutoff point. The European Society of Hypertension adopts, 16 years and 140 as the cutoff point. Whereas the Hypertension Canada guidelines, again, has slightly different cutoffs and, for 6 to 12 and 12 and beyond, as you can see. So coming to the accuracy of measurement, we already heard in the first lecture that, there are many caviars in adults even, and you can imagine that there can only be many more in a pediatric population where the child is probably screaming and crying and may have a developmental problem, or simply not willing to cooperate. So amongst all this, are we really doing justice to the measurement is what we need to just ask ourselves first before, coming to even coming to a diagnosis really. So is the child seated comfortably? Is the cuff size correct? Are we using the auscultatory or oscillatory method? And, at least most of us are using the oscillatory method. But however, we need to be aware that according to the guidelines, if we do find elevated BPs, we need to remeasure them on at least 3 different occasions on different days and confirm that with the auscultatory method. Even on a single day, we might have to measure 3 or 4 readings to get a mean to call it elevated even. So in all this, we need to train our OPD staff because most of us would be relying on them to give us an accurate reading. And there are clear guidelines on the cuff sizes, the bladder length being at least 80% of the mid-arm circumference and the bladder width being at least 40 to 50%. So all in all, BP measurement is both a screening and a confirmatory test. So the rigor of how we take the reading is very important, is what I want to emphasize. Now, in view of the caveats, is it better to also have this tool under your belt, the ambulatory BP monitoring? Absolutely, yes. It is considered a gold standard. However, having said that, is it really accessible is the question. I think Priya ma'am here has done an excellent setup of service at her center, and maybe we could take her help to guide us all. But at least here at Rainbow, we are relying on our cardiology team. But even in spite of having the service, I think we're not making much use of it yet. So we just need to start getting used to doing that more. The indications that ABPM would help us understand is obviously, children being children, they will have a lot of high readings in the office, and it could be each time they come. So even if you do multiple readings, you might still find that it's elevated. What do you do then? So then, having an ABPM to assess for white coat hypertension would always be better before you start thinking of medication. Recently, we had a child with CKD stage 3 with hypoplastic kidneys with completely normal office readings. And then we send them for an ABPM, and it did show a majority of readings above the 95th centile. So, he was diagnosed with masked hypertension. So again, that's a useful reason to do ABPM in a child. Again, having abnormal circadian variations of BP can be, can come to light by doing an ABPM and so on. If the child is on therapy in CKD, again, doing it as an annual, ABPM monitoring would help us understand if we are doing justice to the management. So moving on, the ABPM guidelines, the recent guidelines update in 2022 is what is currently recommended to be used when reporting. We obviously hope that there are many readings that come, but unfortunately in children, again, we see the ABPM reports with, less than 20 readings even sometimes, but ideally it should be at least every 30 to 60 minutes when they are, awake, and at least every 60 minutes when they are asleep. So coming to the revised classification of the phenotype when it comes to ambulatory blood pressure studies. So in case, the child has a normal clinic BP as well as a normal mean 24-hour BP awake and asleep, then they are classed as, as a child with normal blood pressure. However, if the blood pressure in clinic reads high, whereas the ambulatory readings are normal, it is classed as white coat hypertension. For masked hypertension, the clinic readings might be high, but when you actually do an ambulatory reading, the blood pressures are kind of in the higher range. And ambulatory hypertension is labeled if both office and ambulatory blood pressure monitoring readings are above the 95th centile. So again, there are adolescent cutoff points here for 13 and above, which I have mentioned there. So it is, 125 over 75 for a 24-hour mean, and 130 over 80 for awake, and 110 over 65 for asleep BPs. So how these new guidelines in 2022 differ from the earlier 2014 ABPM guidelines in children. So we are eliminating the use of BP load, whereas previously, greater than 25 BP load, greater than 25% BP load was considered pre-hypertension, greater than 50% was considered hypertensive. it has been seen that there is no additional value over the mean blood pressure, in predicting left ventricular hypertrophy or the outcomes that we're looking at, and therefore it was taken off. Again, having a single static cutoff point to define ambulatory hypertension is pretty helpful because it is consistent with the adult guidelines and it avoids confusion about pre-hypertension, severe hypertension, and so on. And it's also, been proved that ABP phenotypes defined with this new system are much superior in predicting BP-related target organ damage. Coming to the causes and implications of primary hypertension. So I think we already mentioned a few, but there are a lot of risk factors that contribute to hypertension of primary nature in pediatric population. Most importantly, the modifiable one being a BMI above the 95th centile and even overweight range is also a risk factor, leave alone obesity. A diet which is high in salt and processed foods, which again we are seeing globally and even in urban cities in India. So a lot of salt consumption, processed food consumption, lack of fruit and veggies in the diet, sedentary lifestyle attached to screens, and poor sleep for, again, reasons of stress, schoolwork, and so on. The non-modifiable factors obviously include the epigenetic factors. In India, again, our population, our South Asian population is prone to hypertension. So there probably are some epigenetic modifications in our DNA that put us at risk. Low birth weight, again, it is known that prematurity, low birth weight, is at a higher risk of hypertension, probably because of intrauterine remodeling, of cardiovascular regulation, as well as metabolic regulation. Probably the organ mass is lesser, and so on. Coming to, what implication a high blood pressure or even an elevated blood pressure could have. Obviously, in children, it's difficult to quantify the cardiovascular event risk because we don't see the cardiovascular event during childhood. But what we can look for and can monitor, as well as can explain to the caregivers, is the concepts of left ventricular hypertrophy, left ventricular mass, proteinuria. Again, impaired cognitive function is one of the target organ injuries. Changes in the retinal vasculature, looking for that, are all signs of targeting organ injury, which can be monitored for in children too. And of course, what we're trying to achieve by doing all this is to reduce the incidence and prevalence of adult hypertension and cardiovascular events in adults, particularly, cardiac, like heart failure, strokes, MIs, and of course, kidney dysfunction. So why bother about asymptomatic primary hypertension in children? So, So basically, the children in front of us who are being told that, okay, the blood pressures are high, how do you actually convince the caregiver that there is a problem? Because the child's absolutely fine, no symptoms. And even as clinicians, we might doubt whether anything really needs to be done about this, or can we just wait and watch? So once we are sure about, that we've made the diagnosis correct, I think it is important to impress upon ourselves as well as our patients and even the general public that there is a reasonable amount of evidence that cardiovascular disease, including elevated BP and hypertension, do develop in childhood and they track into adulthood. So a child that's hypertensive in their early teens might well continue to be hypertensive in early adulthood. And they are the ones who probably might land up into early strokes, early heart attacks, and so on. And amongst, those who develop stage 1 and stage 2 hypertension before the age of 40, the incident rates of cardiovascular disease are, quite high per 1,000 person years, almost up to 8 per 1,000 person years respectively. Although the actual general population rates might be around 3 in the Caucasian and probably slightly higher in the Asian population, but 8 is definitely much higher. So prevalence of adult cardiovascular disease, if you exclude hypertension from the equation, again, from 49%, it comes down to 9.3. So that is quite a significant drop if we're excluding hypertension. So certainly, we do need to do something about this if we pick it up when they are children. Hypertension in adolescence is independently associated with increased left ventricular mass, pulse wave velocity, and decreased diastolic function, which again, there is a lot of data. The SHIP-HOI study also has shown that. So in a sense, hypertension is one of the commonest causes, if we can say, of global morbidity and mortality, and it is reversible cause. So that is why, we must really try and tackle it, in childhood if we get a chance to. So coming to the investigations of hypertension in children, is it primary, is it secondary is the question one needs to ask, because there are quite a lot of investigations that can be done looking for a secondary cause, but do they need to be done in every child? Probably not, because as we had highlighted earlier, the prevalence of primary hypertension is definitely more than secondary. However, if you have a child who's young and who presents in severe hypertension or a crisis or urgency, definitely look hard for a secondary cause. Now, coming to what investigations they could be. So hopefully all the pediatricians in the audience would agree that we would routinely in all these children do a urine analysis for CUE and urine protein creatinine ratio. That could be a spot sample, if possible, a 24-hour, a CBP, RFT, lipid profile, preferably fasting, as well as a renal ultrasound. Renal ultrasound with Doppler, if the facilities are available, would be, you could do it in one go. Again, most of us would be tempted to do a HbA1c, and an LFT screen, even though the child may not be obese, but in obesity or overweight children, definitely that's a must. In terms of what second line investigations we do need to think about. So in case of, you're suspecting an endocrine cause, so basically it all boils down to a good history, a good physical examination, as Manisha ma'am was saying about, looking at 4-limb BP, looking at pulses, looking at any markers of the neurofibromatosis or tuberous sclerosis or any, neurocutaneous markers for that matter, looking at their growth in general, looking at history of UTIs. So all that can help you tailor the investigations down into either, is it an endocrine cause? Is it renal scarring? And is it a glomerular pathology? Do we need to do an autoimmune screen? And so on and so forth. Obviously, echo, although it says on the second line, I think we do have reasonably good access to echoes now. So especially if you're thinking of starting medication, definitely an echo would be warranted as first line test. And again, if there is a history of, apneas and snoring, then a sleep study would be an important one. Genetic test. Can you hear me? Can
we
you
lost you for a
Yes,
moment. Now we
yes.
can hear you.
Yeah.
Yes,
So,
ma'am.
so genetic tests again are, coming up nowadays, and they are quite easily accessible, I must say, at a cheaper cost than they used to be. So thinking about other monogenic causes of hypertension, that is something that is always available to explore if needed. I think my screen is frozen. Oh, yeah. So coming to the management of hypertension in pediatrics, I found this figure quite useful as a poster that could be used. And I just wanted to emphasize the population-based strategies on here. So, we talked about screening, but how, is the public really aware that children need to be screened? Are the pediatricians aware that children need to be screened for BP? Probably not. So increasing the awareness that pediatric primary hypertension does exist and therefore needs screening, and if picked up, referred to the specialists, which would still be the nephrologists in children. So that is something that we really need to probably think about and see how we need to create this awareness amongst the public. Coming to the non-formal pharmacological treatment, there is good evidence that reduction of weight, increasing the physical activity, and the DASH diet, so the dietary approach to stopping hypertension diet, which focuses a lot on reduction of salt and calorie reduction, increasing the fruit, veggies, nuts, and grains, and again reducing the animal protein in the diet, works well to improve the blood pressures as well as the vascular health and affects the cardiovascular outcomes too. In terms of the pharmacological treatment, I didn't dwell too much into detail, but what I wanted to highlight was that we would start immediate drug treatment in case there's a child who is symptomatic with hypertension, whatever the stage be. If it is stage 1 and any evidence of end organ dysfunction, so say for example, left ventricular hypertrophy, or if there are retinal changes that we can see, then definitely we would start medication straight away alongside the lifestyle changes. If it is a stage 2 hypertension, definitely again, immediate drug treatment is indicated, even though it might just be a child with obesity. Because of, leaving a stage 2 hypertension untreated can push the child into a hypertensive crisis. And in case any stage of hypertension, but we do know that this child has a chronic kidney disease or is diabetic or has a cardiac disease, definitely we shouldn't hesitate to start drug treatment along the lifestyle changes. What choice of drugs? Again, it would be basically on the etiology of the hypertension, but first-line drugs still remain the same: ACE inhibitors, or calcium channel blockers, in pediatric primary hypertension. Coming to CKD and hypertension, obviously we all know that hypertension in a child with CKD increases the rate of progression and vice versa. So if we're able to manage the hypertension, we might be able to slow the progression. And one must remember that there is a lot of masked hypertension in the population of pediatric CKD, and therefore, unless we are looking at monitoring through ABPMs, we might miss this category. Generally, we still would recommend the renin the RAS inhibitors as the first line in pediatric CKD too. And what optimal targets are we looking at? So KDIGO recommends that the 24-hour MAP should be less than 120, but that means that we have to do ABPMs to monitor, so that again may not be accessible. Coming to the AAP guidelines, they have a straight guidance that we need to maintain these children under the 50th centile for their age and height, as well as the European guidelines also stress that 50th centile would be ideal if the child is proteinuric, but they'll allow below 75th centile if they're non-proteinuric. This slide is kind of I picked it up from a not recent, but a report 2 years back, which does summarize that we still are not yet there with pediatric hypertension, because the care probably is still quite suboptimal. We are missing the boat with screening. And even if we find elevated BPs, we probably don't keep record of it. The follow-up is patchy. The perceptions of the pediatrician itself on elevated BP might be different. When we make a diagnosis of BP in the hypertension diagnosis, we are probably not following those children up quite regularly. We might be facing a lot of caregiver reluctance, in accepting the fact, and the pediatrician who needs to refer might be concerned about over-referral, and so on and so forth. And once it comes to treatment, again, it's seen that up to 94% of hypertensive children are not prescribed treatment for the reasons highlighted here. So all in all, I think there is a long gap there, and we need to hopefully bridge the gap in time. So my take-home messages for everyone here is that pediatric hypertension is also mostly primary, and therefore we do need to raise awareness amongst the public health bodies, the public itself, as well as our pediatrician colleagues, and impress upon them that this is something that needs screening for. Having the eye of an astute clinician, where a thorough history, physical examination, would help us understand who are those secondary hypertension cases, and then we can channelize the investigations in a more relevant manner. Obviously, our staff in the OPD, as well as all of us, also need to kind of revise how to record BP measurements accurately. We need to remember that there is a good role for ABPM in diagnosis and ongoing management, and therefore strive to have that as part of our department. And obviously, there are enough evidence linking pediatric hypertension to target organ damage. And these target organ damage obviously is associated with cardiovascular events in adulthood. So pediatric hypertension does track into adulthood, does track into cardiovascular events at a younger age. So therefore, we do have a role as pediatric nephrologists to kind of slow that down. If we know the child has got CKD, obviously, we must make sure that we are looking at adequate blood pressure control. And I wonder what the normative data would look like in a South Asian population. But that's something that is, again, not available as yet. With this, I think I finish my presentation. Thank you so much.
Chairperson.
Thank you, Dr. Pratima. It's nice to see you again.
Thank you. Thank you. Hi, Dr. Priya.
For a really wonderfully summarized, extensive talk on pediatric hypertension. Don't know how you managed to fit all that in 30 minutes. I think I agree with what you were saying, that the primary hypertension is probably much more common in pediatrics than we think. It depends on where one is looking. So there are studies that show that secondary hypertension you'll only find in about less than 5% of a childhood screening camp, but 20 to 30% in a referral clinic. So the clinic of a pediatric nephrologist or somebody who sees children with hypertension. And so bringing out your point very well of the importance of screening. And I also agree with you that we do need, if the child is hypertensive, especially significantly hypertensive, to do our best to look for a secondary cause. And primary hypertension would really be pretty much a diagnosis of exclusion in the young hypertensive child. And as Dr. Manisha was saying, really look at fall-in BPs, examine the pulses, because we do get a couple of cases of renal artery stenosis every year. So great talk. And just to add for everyone, since you brought up the point of the need for normative data, that we are about to begin a study. So the weakness of ambulatory BP monitoring, the normative data for children has been that they come from 1,000 German children. Performed 20 years ago, and around the world we are dependent on that normative data. So right now, Dr. Girish Bhatt from AIIMS Bhopal is the PI, and there are 5 centers in India that are going to collect normative ABPM data in 2,000 Indian healthy Indian children.
That's excellent news, actually.
So hopefully we will improve that or work on that challenge.
That's great. That's great news. And wonder what the thresholds would be then.
Yeah.
Thank you for that nice review.
Hello, Dr. Anand.
I'm bringing out various facets of blood pressure in pediatric, right from instrumentation issues to the way we interpret. And of course, the challenges. Of course, the big challenge is facilitating the awareness that blood pressure can be an issue with children in the primary care. That's where we need to have a much focus on because blood pressure is missed even in obvious cases like a child presenting with seizures or a child presenting with a young child presenting with congestive cardiac failure. So that's a big task that we need to do, making primary care physicians aware of that hypertension can be seen in children. Of course, the whole thing of primary hypertension, common or not, it looks, because most of us are working in tertiary care center, so we are biased because most of our patients do have secondary hypertension. And when we looked at the secondary analysis of a large CNNS data of 16,000 children, although it's a single sitting reading of 3 readings, and that's why we call it high blood pressure, not hypertension. We found that 35% of them, especially young children, had high blood pressure. That is more than 95th percentile. So, a lot more needs to be done to uncover this. And the only challenge is that unlike in adult where there's a fixed cutoff value, the whole hypertension in children is, especially less than 13 years, is a statistically derived value. That is, you are taking 95th percentile and above as hypertension. And the evidence that this can lead to, target organ damage on follow-up or in young adult is rather, not consistent. And that is why even the US Preventive Task Force has come up that there's no clear evidence to support or to go against the fact of BP screening in children, in an office setting. But as you said, a lot more needs to be done, and a lot of gaps before we really, firm up on the various quadrants of pediatric hypertension. And normative data is very important because, again, we did look at, using different cutoffs. We have an Indian data of office blood pressures, and they are much higher. And if you use that cutoff, the hypertension, which is 35% using AAP, drops to 18%, nearly half.
Right.
So I think we need a pan-India, as Dr. Priya has indicated, not only in ABPM, but also in ambulatory, office blood pressure recording. Thank you. Excellent talk once again. And I'd like to thank Dr. Priya and the team, Priya John and team from WIN for their kind invite.
Thank you, sir. Due to want of time, we now conclude this session. Moving on, we have an interesting case of hypertension in a child being presented by pediatric nephrologist Dr. Yasmin from Little Stars Hospital, Hyderabad. To chair this session, I invite the chairpersons. I take this opportunity to invite Dr. Sukanya Govindan, who is pediatric nephrologist from Chennai, Dr. Kamini Mehta, pediatric nephrologist from Mumbai. Dr. Yasmin, can you share your screen?
Good evening to everyone. This is a case about 5.5-year-old girl who was referred to us by pediatric surgeon for the evaluation of hypokalemia. She had 2 episodes of intersubscription within a span of 6 months. During both the periods, her blood potassium were less than 2 milligrams per liter. Upon inquiry, the child was not gaining weight since infancy. Mother gave the child was same weight for past 2 to 3 years. There was a history of polyuria, polydipsia, irritability, nausea, constipation, and decreased appetite. There was no history of blood in urine, body swelling, excessive sweating, shortness of breath, mouth breathing, blurring of vision, UTIs, and seizures. Upon coming upon the child's history, child was a firstborn child out of non-consensual marriage, term baby with birth weight of 2.5 kg and antenatal scan showing normal amniotic fluid index. Development-wise, child mental development was appropriate for the age. There was a history of mild delay. Child was able to walk and run around 16 months of age. Child had a younger sibling, a 14-month-old girl. There's a family history. There's a history of sudden death in paternal grandmother around 50 years of age. Upon examination, child weight was 13 kg. It was less than 3rd centile. Height was 101 centimeters, which was around 3rd centile. On checking the blood pressure, it was checked almost 4 times when the child was sleeping in calm position. Her blood pressure was 145/100 in right arm, and the forelimb BP was proportional. Legs were higher than lower limb BP was higher than upper limbs. Child, upon the looking, she was not interested in surrounding, irritable, excessive crying was there. There was no neurocutaneous markers, no radiopharmal delay, muscle wasting, generalized hypotonia, distended abdomen, and normal female genitalia was present. Then coming to investigation, basic investigation was done. CU was showing as 1015, pH of 6.0, nil protein, nil sugar, 2 to 3 WBC and 1 to 2 RBCs. CEP was normal. Serum oxalate sodium was 136, potassium 2.5, and chloride was 114. Blood urea and serum creatinine were within normal range. Thyroid was normal 1.7, and blood BBG showed metabolic alkalosis 7.49 and bicarb being 30.9, and potassium was 2.8. Based on this hypokalemia metabolic alkalosis normal functioning, which further evaluated by doing ultrasound abdomen, which showed normal sized kidneys, CMD was maintained, no cyst, and no adrenal mass was found. Renal Doppler was normal. Then coming to special investigation like plasma renin was done, which was less than 0.5 microinternational units per ml, and serum aldosterone was 1 picograms per ml. This was done after the child was sleeping for half an hour. Then post activity, we have collected the blood samples. Then to summarize, a 5.5-year-old girl with growth failure, polyuria, polydipsia, severe hypertension, hypokalemic, metabolic alkalosis with low plasma renin and aldosterone levels. Based on these findings, we thought a possibilities of Liddle syndrome, apparent mineralocorticoid excess, congenital adrenal hyperplasia, 11-beta hydroxylase deficiency, activating mineralocorticoid receptor mutation, and primary glucocorticoid resistance. Then while sending for genetic analysis, we started on potassium supplementation, antihypertensives like amlodipine, amiloride, less salt and vegetarian diet was started, and home BP monitoring was done. Mother was taught how to check the blood pressure at home. Then seeing any target organ damage, eyes were checked, it was shown no evidence of hypertensive retinopathy. The cardiac showed mild concentric LVH with ejection fraction of 67%. Then genetic analysis report came, it showed as hydroxysteroid dehydrogenase 11-beta-2 gene defect in chromosome 16 exon 3. It was homozygous, suggestive of apparent mineralocorticoid excess. It was a missense variant. Based on this genetic report, we started on spironolactone, mineralocorticoid blocker, which is the drug of choice, and along with amlodipine to control the blood pressure. Child activity has improved. Child started playing. She was gaining weight. Appetite was improving. Blood pressure was better, but not normalized. Then she complained a new onset of vomiting, which was not present earlier. And vomiting is a known complication of spironolactone, and Heracles at that time was 138, 3.0, and 108. Because of this new complication of vomiting, child was restarted on amiloride, amlodipine, and potassium supplementation. Coming to family history, both the parents' blood pressure were checked with normal. Hence, genetic target gene sequencing was not done for the parents. Younger sibling had similar history of failure to gain. She was 14 months old, term baby with birth weight of 2.3 kgs. Her weight was 6.1 kgs, less than third centile. And she too had a history of growth failure and mild motor development delay. Upon inquiry, she too had polyuria, excessive crying, decreased appetite. And when we checked her blood pressure, it was 130/90, and this was during sleep state. Her electrolytes showed sodium 139, potassium 1.8, and chloride 102. BBG showed 7.48 and 29.4, which is showing metabolic alkalosis, and potassium being on lower side. Then she was sent for targeted Sanger sequencing, and she too turned out to be a chromosome 16 exon 3 and hydroxysteroid dehydrogenase 11-beta-2 gene positives, which is suggestive of apparent mineral. So both the sisters had the same genetic defect. Then younger sibling was started on potassium supplementation, amiloride, and amlodipine, less salt, vegetarian diet, and home BP monitoring was done. At the last visit, younger child was playful, walking, and blood pressure being 92/62 and during sleep state. Just to summarize, elder child, upon a period of 1 year, when she was initially present at 5.5 years, at her last visit was 6.5 years, she has gained weight of 4 kgs and height growth velocity of 9 centimeters. Blood pressures were less than 90th centile. Tone has improved from hypotonia, it became as normal. And activity has improved. She became a playful child. Polyuria, which was present at the initial, has resolved. Appetite improved. Both potassium and venous blood gas analysis both normalized. Medication-wise, she was on amiloride and amlodipine. It was continued on amiloride and amlodipine. Possibility of, because of delayed diagnosis, there might be chronic vessel changes. That's why she needed 2-drug therapy. Whereas the younger sibling, in the age group of 8 months, her weight has increased to 9 kgs. Her height has increased. Blood pressures have been normalized. She has been drastically improved. Both potassium and BBG was completely normalized. And initial 2-drug therapy, amlodipine and amiloride, was changed to 1-drug therapy, that is amiloride. Then coming to the discussion part, the monogenic hypertension usually categorized into 3 parts, like excessive aldosterone synthesis, familial hyperaldosteronism, dysregulated adrenal steroid metabolism action, in which we have apparent mineralocorticoid excess, congenital adrenal hyperplasia, activating mineralocorticoid receptor mutation, primary glucocorticoid resistance. In both, all these categories have low aldosterone renin ratio. The other third category is hyperactivity of sodium and chloride transporter in the distal tubules. And a few points about apparent mineralocorticoid excess. Here, mainly the basic defect lies in 11-beta hydroxysteroid dehydrogenase. Here, the main 11-beta hydroxysteroid converts the active cortisol into inactive cortisol. Usually, the mineralocorticoid receptor has affinity for both aldosterone and cortisol same way, but intracellular cortisol level is very high. Because in this, when the defective enzyme is present, there is a mineralocorticoid overstimulation by cortisol, causing sodium upregulation of sodium absorption and increased potassium loss and low renin level. The presentation usually is low birth weight. The 11-beta hydroxysteroid is also present in placenta, brain, colon, and sweat glands. In fetus, it acts as a glucocorticoid barrier. So it presents from maternal excess of maternal corticosteroids. When this enzyme is defective, the fetus is exposed to the maternal corticosteroid causing IUGR. There's a growth failure and polyuria and polydipsia. Polyuria and polydipsia can be explained because of secondary nephrogenic diabetes caused by chronic hypokalemia. Hypokalemia, metabolic alkalosis, hypertension, nephrocalcinosis, renal cyst. This is also due to chronic hypokalemia. Then sequelae, because we have uncontrolled hypertension, this is the outcome. Left ventricular hypertrophy was found in 75 to 79%. Hypertension retinopathy in 63 to 71%. Neurological features like stroke and intracranial bleed was found in 57%. Aortic insufficiency in 15%. Coming to investigation part, usually the special test, basic test, renin level and aldosterone. We have both low aldosterone renin ratio. Then other urinaries, 24 hours urinary free cortisol and cortisone ratio, or ratio of their metabolites like tetrahydrofluorocortisone, allohydrotetrahydrocortisone, but tetrahydrocortisone. We could not do the urine test in our patient because the child was a young child and girl child. To collect a 24 hours, it's cumbersome. So directly we went to genetic test, which is whole exome sequencing. Based on whole exome sequencing, the drug of choice is mineralocorticoid receptor antagonist, spironolactone, eprenol. Eprenol has benefit has over androgenic effects over spironolactone. And ENaC channel blockers, amiloride can use in refractory cases, calcium channel blocker, amlodipine, and basically it is low salt diet because it is salt sensitive hypertension. Then coming to the review of literature, the first clinical symptoms were described by Werder et al. In a 3-year-old girl child who presented with polyuria, polydipsia, and severe hypertension. Then the first mutation was diagnosed in 1995 by Wilson et al. He has found the gene in the chromosome 16 in exon 3 to 5, and 3 to 5 is the most prone to undergo mutations. Then in 1999, the first correlation between genotype and phenotype was seen by Nunes et al. In Iranian siblings, in consanguineous marriage children of Iranian siblings. The longest follow-up of 20 years in 3 Iranian siblings was done by Razgrave and Azar et al. He found the elder sibling, because of delayed diagnosis, had developed both cardiac and renal target organ damage, whereas the 2 younger siblings who were detected earlier had no end organ damage at the follow-up of 20 years. Then long-term follow-up was done in 36 patients by Ya et al. He found cardiovascular mortality to be 19%, nephrocalcinosis in 89%, and kidney failure in 15%. So basic take-home message is any child presenting with growth failure, polyuria, polydipsia, and significant family history of early onset hypertension and stroke, it should be evaluated by serum nitrate and venous blood-based analysis suggestive of any hypokalemia metabolic alkalosis. Usually we think hypokalemia metabolic vomiting-induced diuretic, Bartter syndrome. In that way, usually miss to see hypertension. So the blood pressure should be checked in all the children during first visit of any OPD. Other causes of hypokalemia metabolic alkalosis, renal, vascular, aldosterone secretory must be excluded. Plasma and aldosterone level be checked. And nowadays, affordable and precise genetic analysis available, which was not there in previous days, which can be used for specific diagnosis and individualized treatment. Timely diagnosis and treatment will decrease the mortality and improve the long-term outcome. Thank you.
Thank you, Dr. Yasmin, for such a nice case presentation. It was really a nice case, and you managed it, your team managed it very well. Especially picking up that younger one, that was a very nice thing. We always should screen the other siblings if we have a genetic problem sitting over there. And we do have a similar case. That boy presented at around, less than 1 year of age. Now he's 16 years old. We have a follow-up. The child has been, he requires potassium supplements. I think in your patients, they did not require potassium supplements. They are only on drugs. But our child requires a significant dose of K-sol, which he's really not wanting to take it. And he's still on amiloride also. And he's on spironolactone also. And we have put him on ACE inhibitors for nephroprotection. We have almost 15 years follow-up. Similar, one child died, first baby died, male child only, and that baby died within a few months only, maybe because of hypertensive, some complications. And LVH and all we are monitoring, but the child is, okay, and blood pressure is at least 130, 140 systolic, and around 80, 90 diastolic we are able to maintain. So very nice presentation, and I think eye-opener. And now because we have availability of whole exome sequencing, it is become very easier, than before. And cost is also not very much. 14,000-15,000 whole exome, I think we can do. So it becomes easier to, diagnose such patients. Dr. Sukanya, I think your messages we are reading, you are driving. and your connection is patchy. So even she is thanking you, Dr. Yasmin, our other co-chairman. She's driving and she's unable to, join because of the patchy internet problem. So thank you so much. And thank you, Dr. Priya. Thank you so much. It was a pleasure.
Thank you, Dr. Yasmin. Thank you, chairpersons. Moving on, after hearing much about medical management of hypertension, where do the surgical options for hypertension stand, and what is the role of hypertension in role of surgeries in hypertension? We now have a presentation from KIMS, Krishna Institute of Medical Sciences, Secunderabad. I invite Dr. Razia to present her case. To chair the session, I invite the chairpersons. I invite Dr. Manjusha, Professor, Head Department of Nephrology at Gandhi Medical College, Dr. Sati Reddy, Senior Consultant Nephrology from KIMS, Secunderabad, Dr. Padmanabhan, Vascular Surgeon from KIMS, and Dr. Girish Reddy, I don't know if he's here, Interventional Nephrologist from INU, Bangalore.
Thanks, Dr. John. I mean, it's pleasure that we have heard a lot about hypertension in various age groups. Now, moving on to another entity, which is, I think, is for only nephrologists, is transplant hypertension. So post-transplant, we know that hypertension is again challenging. We have various categorization, classification of the hypertension post-transplant, whether depending on the duration of the time of onset, or probably the persistent hypertension, resolving hypertension, or probably a de novo hypertension. We all know one entity which is of major concern for us in the post-transplant scenario is post-transplant renal artery stenosis. So let's learn from the team KIMS, which apparently has a very good experience with respect to the management of transplant renal artery stenosis with its interventions. They have a case series apparently. So we have Dr. Razia, who is second-year DNB resident, presenting to us the experience of KIMS with respect to trust. Over to Dr. Razia.
Good evening, everybody. This is a single center experience of transplant renal artery stenosis and the clinical outcomes of angioplasty. Transplant renal artery stenosis is a well-recognized vascular complication after kidney transplant. It occurs most frequently between a period of 3 to 24 months post-transplant, and the incidence is around 1 to 25%. Renal hypoperfusion occurring due to transplant renal artery stenosis results in RAS activation, leading to refractory hypertension and fluid retention, followed by allograft dysfunction. Coming to the materials and methods of this study, it's a single center retrospective review of all the post-transplant renal artery stenosis occurring in between 2014 to 2023. We have around 840 transplant patients, out of which the patients with Doppler sonographic abnormalities and graft dysfunction were taken. And there was also a criteria of worsening hypertension. In Doppler ultrasonography, a peak systolic velocity of more than 200 centimeters per second and reduced RI of less than 0.5 and presence of spectral broadening were considered. In suspected cases, CT angiography or MR angiography where the graft dysfunction was severe were undertaken, and some were directly taken up for conventional angiography and ad hoc angioplasty. Percutaneous renal vascular procedures, either balloon angioplasty with or without stent placement, was done in 70% of the patient. Was done in patients with more than 70% stenosis. Creatinine before the procedure was noted, and patients were followed up for a period of 12 months post-procedure, and clinical examination and drug history of all the antihypertensive drugs were recorded on the OP basis. These are the demographic profiles and the presentation and the clinical examination findings. First case was a 63-year-old male of deceased donor who had a transplant renal artery stenosis 6 months post transplantation, and the anastomosis of the transplant artery was to the internal iliac artery. He presented with a 70% stenosis. He also presented with refractory hypertension. Pre and post procedure creatinine levels are mentioned, and there is a reduction in the creatinine level after procedure. The second was a female patient with 6 months who has presented 6 months after the transplant. Again, anastomosis was done to the internal iliac artery with an 80% stenosis, and the primary presentation was of graft dysfunction. And following the procedure, the graft dysfunction has improved. And third one is a living donor allograft recipient of a 38-year-old male presented with a history of post-transplant renal artery stenosis at 20 months. This was the vessels were anastomosed to the common iliac artery, and because there was severe atherosclerosis to the recipient blood vessels, the endarterectomy was done on the table. And there is 60% stenosis, and because this patient presented with uncontrolled hypertension, he was taken up for a renal transplant renal angioplasty, and the creatinine was followed up, and there is no significant improvement in the creatinine in the graft function, but the hypertension has settled. The next one is a living donor, again a 31-year-old male who has presented 4 months post-transplant. The anastomosis again was to the internal iliac artery. He had a critical stenosis of both the branches. These were a double artery where the accessory and the main renal arteries were transplanted to the internal iliac artery. And he again presented with only mild graft dysfunction and refractory hypertension. He has also improved. Then again, the fifth case is a 28-year-old male with a living donor allograft, who is a living donor allograft recipient, who has presented 12 months post-transplant, again an anastomosis to the internal iliac artery, presented with 70% stenosis and the graft dysfunction. But sadly, we had lost this patient post-transplant, and this was secondary to a hematoma, which has led into infection and sepsis and shock and death. The third, sixth patient, he is a 33-year-old male who is a living donor allograft recipient, presented 4 months post-transplant. He had a double artery, which were anastomosed to the common iliac artery. And there was a tight stenosis at the anastomotic site. Then again presented with a graft dysfunction. And again, we had lost this patient because of post-renal transplant angioplasty, and the graft has become ischemic. And 48-year-old living donor patient with a 7-month history of presentation. Again, anastomosis was done to internal iliac artery, has a 60 to 70% stenosis at the anastomosis, presented with the mild graft dysfunction, and there is a stable graft function post-procedure. And 37-year-old male, again a living donor transplant, presented 18 months post-transplant. This anastomosis was done to an external iliac artery. A Doppler was suggestive of stenosis. This patient was taken to an ad hoc conventional angiography, and this patient is actually we had lost this patient to follow. Coming to the results, 8 patients out of 840 post-transplant patients had transplant renal artery stenosis. The age group of presentation were between 25 to 65 years of age, and the patient presented with graft dysfunction and controlled hypertension or both. 7 out of 8 patients were males and 1 was female. Majority of the patient had undergone a living donor kidney transplant of 75%, and 25% were cadaveric transplants. Coming to the time of presentation, less than 6 months, 50% patients had actually presented within 6 months of transplant period, and 25 patients were between 6 months to 1 year, and 25 were more than 1 year. Graft dysfunction was found in majority of the patients, and 1 patient has a double renal artery. Both branches had stenosis, and 7 out of 8 patients had underwent stenting, and 1 out of 8 patients had undergone only balloon angioplasty. Coming to the outcome at our center, 75% had improved graft function, and we had lost 2 patients, that is 25% had graft loss. And the risk factors of this post-transplant renal artery stenosis were hypertension, dyslipidemia in 3 to 8% of people, and atherosclerotic disease in 1 out of 8 people, and TCMR was present in 1 patient. Coming to the discussion, hypertension is a very common problem following kidney transplant with a prevalence of 80 to 85%, whereas resistant hypertension, which is defined as a blood pressure remains above the target despite use of 3 or more antihypertensive medication, affects only 7% of the transplant recipients. Transplant renal artery stenosis is potentially a reversible cause of refractory post-transplant hypertension, whereby narrowing of transplant renal artery impedes the blood flow and results in renal hyperperfusion. At its most severe, it can result in hypertensive crisis and flash pulmonary edema. It is also called as Pickering syndrome, which is explained by Goldblatt's single kidney, one kidney, one clip hypothesis. And graft dysfunction in the absence of any other cause is indicative of critical stenosis. The site of TRAS can be localized to the localized stenosis, either proximal distal to the anastomosis at the anastomotic site, or it can be diffuse at or may be present at multiple sites. Coming to the risk factors, the recipient factors are older age, diabetes, hypertension, ischemic heart disease, dyslipidemias, rejection, mostly ABMR, and CMV infections. The donor criteria include extended donor criteria and fibromuscular dysplasias, especially in deceased donors because of a lack of screening prior to the transplant. And surgical causes can be suturing errors, end-to-side anastomosis, and trauma to the donor or recipient vessels, or prolonged cold ischemia time. And delayed graft function is again one of the very important risk factors for TRAS. Surgical causes of transplant renal artery stenosis present early, that is within 3 to 6 months post-transplant, and stenosis is mostly at the anastomotic site. Atherosclerosis renal disease can present very late during the post-transplant period. The diagnosis is not always straightforward and depends on a high index of suspicion and choosing an appropriate imaging modality. Doppler ultrasonography imaging is readily accessible and non-invasive tools that can identify TRAS, but is highly operator dependent and requires assessment of low resistant injects and high peak velocities. The following ultrasound parameters can be taken into consideration. One is the peak systolic velocity more than 200 centimeter per second, or the ratio of renal artery velocity to the iliac artery velocity more than 1.8, and intraparenchymal arterial resistive index less than 0.5, and intraparenchymal arterial systolic acceleration time more than 0.1, and there is presence of spectral broadening. If we use all these 5 modalities, the sensitivity and specificity will increase up to 97% and 91% respectively. These are the pictures showing a normal flow in the renal transplant renal artery with a normal resistive index and a pattern of waves where there is no spectral broadening. And for the comparison, this is again one image showing a very tight stenosis at the anastomotic site, leading to a spectral broadening and reduced RI of 0.46, and peak systolic velocity are 429. CT angiography shows 3D imaging of vasculature but requires exposure to the contrast agents, which might not be feasible in all the patients who are having graft dysfunction. MR angiography is another alternative, but there is always a risk of overestimation of the stenosis. Invasive arteriography is a gold standard modality, often providing a definitive diagnosis while simultaneously allowing for the treatment. More than 50% occlusion in the lesion is considered diagnostic. Other modalities can be a plasma renin activity estimation, which is less reliable, and captopril renogram with MAG3 and CO2 angiogram. CO2 angiogram actually reduces the risk of exposure to the contrast agent. The management of transplant renal artery stenosis is tight control of hypertension, use of antiplatelets and statins, and revascularization modalities. The indications of revascularization modalities are failure to control blood pressure or intolerance to the medication, deterioration of graft function on medication, and recurrent flash pulmonary edemas, and unexplained worsening of graft function. The indications of revascularization are stenosis more than 70% with a gradient across the stenosis of more than 15 mm Hg. The choice of treatment can be surgical revascularization or percutaneous balloon angioplasty with or without deployment of a stent. Surgical revascularization can be reserved to patients with proximal recipient atherosclerosis, arterial kinking, or long regions. The rest of the patients can safely undergo a percutaneous angioplasty with or without stenting, and its success rate is around 80%. And 20% may always have a risk of restenosis. Conclusion: transplant renal artery stenosis is a reversible cause of worsening graft function post-transplant, and percutaneous arterial stenting provides an excellent results. Thank you.
Excellent talk, Dr. Razia. I think the team came as a fabulous experience with regards to the transplant artery renal artery stenosis, and of course the management as well. A good case series. A couple of questions actually. Before that, can I request the co-chairs, Dr. Sathireddy and Dr. Padmanabhan, who are here, to share their experience as to how they have gone about the revascularization technique, and did they have any re-stenosis as well, or is it only simple angioplasty vis-a-vis stenting with angioplasty? Over to Dr. Sathireddy, followed by Dr. Padmanabhan, who are waiting. Yeah, Dr. Sathireddy, sir, please.
Most of these cases, 7 out of 8 cases, we did stenting. And in few cases where the renal arteries were very small, we had to use drug-eluting stents. And all these interventions were done by Dr. Padmanabhan, sir. So I request Dr. Padmanabhan to comment on this.
Yeah, thank you for inviting me to be part of this August conference. It's really nice working with our nephrology colleagues and getting exposed and learning something which is new to us. And our experience has been, as Dr. Sathireddy mentioned, so mostly we try to do stenting rather than balloon angioplasty, because the restenosis rates comes down when you use a stent compared to plain old balloon angioplasty. So we tried to do in only one case where it was not suitable because it was in the ostium of the renal artery, we couldn't place a stent. Fortunately, in whatever follow-up we had not encountered any cases of restenosis. Whatever problems we had were in the immediate post-procedure, where we had a thrombosis and hematoma compression, and we had graft failure or a stent failure. Other patients are all doing well in the long-term follow-up. Any questions from the audience?
Sir, are there any particular indications that you will do stenting in certain situations and only angioplasty in certain situations? And Sathireddy sir, what is the long-term outcome in these patients? I know you have a case series, but what is the longest follow-up of these patients?
5-6 years. Means two patients died because of some other reasons. One had graft pyelonephritis 2 years after stenting, and other patient had respiratory tract infection, and then he succumbed to death. Otherwise, all others are doing well. Okay.
That
So
is
restenosis, and then
I mean, restenosis, was it there during your follow-up? And then the graft function, sir, the graft function, once you have corrected, I think Razia has projected that there's a reasonable reversibility in good number of patients with regards to the graft dysfunction, which initially was there and reversed with the stenting. So over a period of time when we followed up, the graft function remained normal or something, or were there any other factors which had caused the graft dysfunction as well?
Yeah, that out of 8, 2 had complications immediately after stenting. One had hematoma and other had thrombosis. Remaining 6 patients, 2 had pyelonephritis and then pneumonia. Other 4 patients are doing well. So their creatinine is stable and then it's reasonably well maintained.
And how about the requirement of the antihypertensive drugs post-stenting and all? It has come down?
Yeah, significantly came down after stenting. So they were using 3-4 drugs before stenting, and post-stenting, they are requiring only 1 or 2 drugs.
So what are the challenges that you face during the procedure of stenting, sir, Dr. Padmanabhan, sir?
Yeah, it depends upon the site of anastomosis. See, we find it easier to approach if it is connected to internal iliac artery rather than external. When it is to the internal iliac artery, you go from the contralateral femoral, because the angulation of the internal iliac is very acute when you go from the same ipsilateral. So we choose a crossover sheath, go for contralateral, which becomes much easier. If it is an external iliac, it becomes very, very challenging. The reason being, when you are approaching ipsilateral, the length of the sheath will be almost sometimes goes across the anastomotic site. The sheath we use, this 13 centimeters itself, may sometimes be beyond the anastomotic site. So you can only push the sheath halfway and then approach it. Contralateral is very difficult for external iliac anastomosis because the takeoff will be at an acute angle. So these are some of the technical difficulties. And by and large, whenever we are intervening, the worst part we've encountered is all these patients' hypertension was very, very uncontrolled, mostly beyond 200. So we had access site bleeding. That is the major challenge we had. Post-procedure, of course, the BP control is good. But most of the patients, our nephrology colleagues suspected when the hypertension is not getting controlled, and similarly slight rise in the creatinine after coming to a NADI. These are the two things when they suspect and do a Doppler and then evaluate and refer to us.
Yes, sir. I understand the bleeding will be a very significant complication with the pressures being on the higher side, and then controlling the bleeding during the procedure definitely becomes challenging. Sir, Satyareddy, sir, are there any predicting factors, risk factors that you have seen in your case series that, okay, these patients might go like disease versus life, men versus women, or diabetes, like the conventional factors, whatever has been projected, are they the same in your case series as well, or little that different?
So in our series, none of them are diabetics. The incidence of stenosis is more in diabetics, but none of our patients are diabetics, and most of them were live-related transplants, and anastomosis was to the internal iliac artery. So literature says that external, when you anastomose N2 side, there is turbulence and the risk of stenosis is more. But in our case series, most of them are anastomosed to internal iliac artery. So none of them had resection. One patient had T-cell mediated resection that can also predispose to sometimes renal artery stenosis. The only problem we encountered was patients with graft dysfunction in whom we could not do CT renal angio. We did MR angio in few patients. So MR angio overestimates stenosis. So when we took them for conventional angio, then most of them are found to be either normal renal arteries, or when there is a kink, MR reports it as stenosis. So we had difficulty in diagnosis, but when we took them to the cath lab, either the stenosis was not very significant or it was not at all there. So MR overestimates stenosis. So, and few patients deceased donor transplant, 25% were deceased donors, so they had stenosis. So majority were end-to-end anastomosis.
Right, sir. Thank you, sir. Thank you so much. I think lots of learning regarding the trans. I don't think anybody else has got such a huge experience. I'm not sure what the literature says, but then I think we should congratulate the team for a great series that they are holding on. And of course, I think you're going to throw some light through your publication that these are the potential risk factors for TRAS, and TRAS can be treated, and the sustainable treatment can be given for the reversal of the TRAS management as well. Congratulations to the team, KIMS. Thank you. Thank you so much. And if any other questions are there on this aspect, I think the experts can take the questions, or if there are no comments, I think I hand over the proceedings to the host.
Can I comment, Manjusha? One comment.
Kiran, please go ahead, Kiran.
Congratulations, sir. That was very, very interesting. So many huge volume of cases you have dealt very aptly and very nicely. But I have a question, sir. Actually, what percentage of your arterial kink or cases have presented as renal artery stenosis for you? Are they external iliac artery anastomosis or they are internal iliac artery anastomosis? Was there any difference actually?
So I do not remember the percentage, but there are 4 or 5 cases in whom we suspected they had uncontrolled hypertension and then a graft dysfunction, whom we did MRI. We had 4 such patients, and then most of them are anastomosed to external N2 side anastomosis, external iliac artery.
Anyway, congratulations, sir. Such a volume of cases are very nicely managed, sir. Congratulations. Thank you for presenting. Thank you for sharing, sir.
Thank you, Manjusha.
Question, Satyareddy. So what indications that you have taken up, like the patient is on 3 drugs, 4 drugs, or I mean, you have or renal dysfunction ongoing, like rapidly progressing or something like that. What are the classical indications that you have taken up for stenting in your series?
There is recent worsening of renal dysfunction or recent worsening of hypertension. In those patients, we suspected renovascular renal artery stenosis, and then we did Doppler. So most common indication is sudden worsening of hypertension and graft dysfunction. These two are the indications.
You didn't go according to the structural stenosis of, classical 70%, critical, and all these things. Those were not taken into consideration, only the clinical.
After Doppler, whoever, after Doppler, then we did either CT angio or sometimes if the suspicion is very high, we straight away went ahead and did conventional angio and then it started. So for almost all our patients had stenosis more than 70%.
Satyareddy sir, if I can just make a comment. I remember our patient, transplant patient, actually he landed up in KIMS hospital for an emergency, hypertensive emergency. And he was picked up to have renal stenosis, underwent stenting, and he was referred back. So, I remember recently, that's, almost a year back. So, in fact, that was, diagnosed and then treated there and referred here. By the time we realized it was already done. But what I feel is, uncontrolled hypertension and, Doppler in-house we regularly, get it done as a, regular follow-up, during regular follow-up. So Doppler is good enough to pick up renal stenosis at the earliest, unlike the native kidneys where it's very difficult and it is not very what called sensitive. So it's very sensitive and specific in the graft renal stenosis, which can very easily picked up and then, can be managed.
Yes, madam. That was deceased donor transplant done at, he was our patient who was on dialysis. So underwent deceased donor transplant at NIMS and then for the management of renovascular hypertension, he came back to KIMS.
Thank you. If there are no comments, I think I hand over the further proceedings to Dr. John. Thank you so much, sir, Satyareddy and Padmanabhan sir, for joining us and sharing your experience. Thank you so much.
Yes, thank you, Satyareddy sir. Thank you, Padmanabhan sir. Thank you, chairpersons. Anything we do post-transplant is an absolute joy. More so, controlling hypertension with minimal drugs is definitely a joy to see our patients that way. Yeah, we truly had engaging and enriching discussions on hypertension today. Now we conclude today's webinar. I invite Dr. Kiranmay Ismail, professor of nephrology at Osmania General Hospital and president of WIN-TS, to give the concluding remarks.
Thank you, Priya. Thank you. I should thank everyone actually, but I don't want to thank, but a few comments from my side. All good things in life come to an end. So our webinar has come to a conclusion. We have been learning and acquiring knowledge for the last 2 hours, especially from Dr. Swapnil sir's excellent presentation, which has reinforced our knowledge and helped in acquiring new knowledge as well. An excellent presentation by Dr. Pratima, very lucid presentation about hypertension in children. A very interesting presentation by Dr. Yasmin. And Satyareddy sir has presented a volume of cases where he has very efficiently managed post-transplant transplantation. Very interesting presentation as well. And I would actually congratulate Dr. Priya, who has curated the whole program. On top of it, our postgraduate has presented very interesting presentation at Takayasu arteritis. All in all, this webinar has presented the different aspects of hypertension, different presentations, and we have learned everything. It has come to a conclusion. In future also, from WIN India, we would be presenting such an interesting compositions of cases and seminars, topics. And I thank everybody who has actively participated, actively presented, and actually helped in acquiring this knowledge. Thank you very much. Thank you, Manjusha, for curating such a great program as well.
Thank you, everyone, for joining today. Have a great week.
Thank you all. Bye. Thank you.
Thank you, everyone.